today this program of NMC, it is the last part, closing part of the NMC, because the time with 22nd June is very, very less. Today we have to decide how we are going to proceed. And with us today, the whole, whom I think my mentors, all are here. And the first time with IMA, we are working, and I'm very, very, I can say, humbly, I say, bow my head to all two of them. They have joined only on a call or just on a WhatsApp message. Thank you so much for joining, because it is not OBGYN problem. It is a problem of all doctors. And together, yes, we can make a difference. It is my philosophy. If we work hard, we will get it. Whatever it is, if other person think that we are working really hard about it, we will get it. So first, I will welcome Dr. Sahajanand Prasad Singh, although sir is not here, but only with his permission, the IMA headquarter has joined, and we have other representation of IMA headquarter. Dr. Jayalal is here, who was immediate past president, and we have done lots of webinar in her leadership, in his leadership last year as a Haryana public education and the academics chairperson. Welcome, sir. Today, I'm going to do, I will invite one after one stalwart, and please quickly in a crisp way give your views in a 2-3 minutes, so we can forward towards the talks and then a fruitful discussion. So Jayalal sir, over to you. Excuse me, I will not going to read anybody's CV, because we all know everyone.
Thank you very much, madam, for this opportunity to be with you. I know that the amount of work the last month, all of you are putting together to make this most important exercise which we are doing at the overall interest of the well-being of our medical fraternity. I think this is an opportunity given to us to respond to the, there's some regulation which has been drafted by the officials inside the AC room and put into practice. I think many of the things, first of all, we thank the NMC for at least the proactive step they have taken. At least it was a pending for a long time, and now they have done this work and they are publishing this. But I am sure the intention with which they have put it in the draft for the public opinion must be respected by the NMC. By going by their past experience, when they are published the PG draft regulation or the UG draft regulation, most of the 99% of our suggestions were not taken up by them. They were sticking on to whatever they are putting on there. So that is a one with a pain that we are not going back, and we are taking all the steps to see to that this regulation is going to be taken some positive changes. This all comes only when all of us are working together. I am so happy, and this time all the organization, irrespective of their stature, are coming together and putting a solid, brave front. I think IMA is doing its great job, and today and tomorrow we are going to have finalized our draft. We are going to submit, and I'm sure Dr. Neeraj Nagpal and other people has put a lot of efforts on that. Everyone's view are important. Everyone's perception is important. So putting together is a big job. I'm sure Dr. Ragini and all will be able to do that in a proper way. I'm much concerned about the definition which they are going to put for the modern medicine, and if it is not a proper definition, if it is going to be in the future, the intention of the government to make mixopathy or other system to peek into that area, that we need to be extremely cautious. Another one of the great struggle which we are doing for a long time is the CPA. We want to remove the CPA. Now the power of even the punishment powers, monetary punishment power is given to the MFC. So this is appropriate time that we should be vociferously also asking that the CPA should be taken away from us, and we will be abiding with the NMC guidelines on the punishment, but they need to be there. There is definitely the contentious issues on the degrees which we are going to use on the background. We know that it is just because there is a one NMC recognized degree, but other fellowship degrees from the Indian societies or the international societies, if not recognized, so that will be also a great concern for us. First of all, we are recognizing a fellowship from the Western countries, but we are not recognizing a fellowship from the standard Indian respective association. So we should also rise to the occasion that respective associations are also growing to that level. At least the legitimate degrees, which are legitimate fellowship, which are offered by the association, should be also included into that. I am so happy that many of the issues are being discussed and widely it is being taken up. In 90% of the issue, I am seeing that we are all in one line, except in a few issues and few things which we have a difference. But at least the points where we are able to agree on together, I think that is a good step which we need to do that. And at the end of this session, I am sure the consensus document, irrespective of it is the whose point or whose not point is not there. If we can include, it will be always good. I always believe in the statement: if you are not worried who gets the credit for what we are doing, definitely we will be able to do much more good work. Unfortunately, IMA is now open. We do not want to get any credit on this, but we will be also be a part of it, and we will be able to working hard because as a large representatives, because we are getting the opinion from almost all the state, all the branches, all the members, and that is being collaged, and that will be also submitted. But only assurance I can give you: 90% of the suggestions what we have received is almost same with what we are coming out of there. So there is a reinforcement. There is definitely a good job which has been done. In my experience, we are not done like this in the previous episode. So this is an important moment and a crucial moment before 22nd. If all of us can put our mind together and put in a consensus statement, I think it should be go. And we should also will not stop short with that. It is not just sending that, and we must use all our powers, all our lobbying methods to see to that these things are getting into that. In a government setup, it is not the agitation alone will help it to help, but lobbying has a very important power. Every one of our doctor has a very important role, very important close relationship with NMC. Whoever it is need not be an association, need not be an organization, but individually that we need to take up the responsibility as an overall interest of the society. And even after sending that, and we should see to that the lobbying at the floor level, at the voice being influenced, and the ministry level should be able to be carried out. IMA will be there in the front line, but I expect every one of you to also take up an opportunity to lobby so that our points will be taken. At the end, it's a parliament democratic system like this. When many of us can put up pressure, when many of us will be able to make an a force will reckon, I think definitely we will be able to make some important change. Because if you are failing it there is a great betrayal we are going to for our future generation of the medical fraternity. And many of us are now probably crossing our time of medical practice, but we must be remember our young graduates and young people who has to face this problem and who has to get a better practice. So it is our solemn duty and responsibility to see to that we are protecting the interest of the doctors at this moment. So I wish all the best for this team, and always we are there to be with you and continuously to see to that some positive changes are made in this NMC trap. Thank you very much for this opportunity.
Thank you, sir. Now our Chief Patron, Usha Madam, has joined from the Perth. Madam, kindly give some suggestions so we can move forward.
I must congratulate you the way you have taken these things, and I think it's your effort which has just kept every one of us together, and we are doing this job because we know that most of the time, whatever guidelines are made, usually in the past experience, whatever I have, there was always a representative from Foxy or IMA or anybody else so that they can put their views also in these things. But unfortunately, this time, I don't think any one of us was taken into confidence and these guidelines were made. Now, few things are so disturbing because they are talking about the rights of the patients and responsibilities of the doctors, but they have not talked anything about the rights of the doctor and the responsibilities of the patient. We know that, like they have done, that we should keep the records for 3 years, is it possible for anyone to keep the records for 3 years? If everything is okay, I don't think we should keep the records for more than 1 year, because we all know everybody does not have such a big paraphernalia of the helpers that they can keep the record for such a long time. And not only this, whenever a patient has a complaint against any doctor, the time they have given is he can complain against any doctor within the 2 years. Why such a long thing? If there is any complication, if there is anything, usually the genuine complication or genuine complaint can be formed and can be lodged within 4 to 6 months. So I don't think that this 2 years has got any significance, and it is not at all good. Then generic medicines. Now, what I say, that government has the power because they are giving the license to sell these drugs. Why can't they ban the non-generic drug if they say like this? They should tell them that you should keep only generic drugs. Now, one thing which I always feel in the country, the worst thing is that most of the drugs are available on the counter. Not only analgesic or the things from anything, वो कहते हैं ना कि analgesic से लेके और poison तक, anything you can get on the counter. Why? In any other country, like in foreign countries, you always say that they do not get any medicine without the prescription. So these things are to be, can be just put in the guidelines that the prescription should always be there whenever anybody wants to purchase a medicine. And on the counter, we should not keep if you don't want non-generic. But they have never stopped anyone. A patient, he just goes to the Google and just find out the name of the drug. And then one thing more I would like to say, there are few drugs. All generic medicines do not have the molecules we need. And there are few drugs in which we have to introduce molecules, and then for those molecules you have to give. But certainly only registered medical practitioner can prescribe those medicines, and whenever they prescribe, they always write the diagnosis and why they are doing. Then the other thing which I would also like to say, that as just now Dr. Jayalal said, that if we are having any fellowship or if we can't write, why not? This is like something, a few specialties are such जिसमें DM, MCH, MD, DNB नहीं होता. जैसे मैं एक एग्जांपल में कहती हूँ एंडोस्कोपी. एंडोस्कोपी के लिए कोई अलग से डिग्री नहीं है. But suppose somebody has taken the fellowship. One thing I will certainly say, that if we write a fellowship, that fellowship should be achieved after a proper training. Few fellowships are such that you pay the money and you get the fellowship. That is not correct. But these fellowships which we just go and attend a proper training and then we get, we should allow to keep those, to write those in the our banner or whatever it is, board, that you can write those medicines. Then I will also like to say that these academic activities, if we participate, and pharma people, they help us to organize a conference to update our knowledge. NMC or whatever, when it was MCI, they always want, आपने कितनी conference attend करी है, आपने कितना क्या करा है, आपको इतने credit मिलेंगे, आपको even promotion के लिए इतने paper publish करने, इतने paper पढ़ने, नहीं पढ़ेंगे तो आपको करेंगे. When you are asking for all these things, how can you ban कि किसी तरीके से फार्मा वाले किसी कॉन्फ्रेंस को ऑर्गेनाइज करें? हाँ, दिस आई सर्टेनली एग्री कि आपको किसी को बड़ा स्ट्रॉन्ग सपोर्ट नहीं करना है. You don't have to project any pharma, but certainly these conferences which can be organized by these pharma companies, we should not ban them at all. देन मैं अपने राइट्स के लिए जरूर कहूंगी कि हम लोगों का एक तो कंज्यूमर फोरम, आई थिंक एक मेडिकल प्रोफेशन ही ऐसा है जिसमें हमें कंपनसेशन देना पड़ता है। क्या कभी सुप्रीम कोर्ट का लॉयर अगर केस हार जाता है तो क्या वो कुछ पैसे देता है? Because these things are such that we have to highlight, and the only thing is that many times we do not support each other. And that is the main thing I will like to request all the members of medical fraternity to please support each other. Sometimes the legal problems which we face is only due to this कि हम ही अपने लोगों की वीकनेसेस बताते हैं और वकील लोग आगे आके उन्हीं वीकनेसेस को सामने कर सकते हैं। तो इन चीजों के लिए हम लोगों की भी कोऑपरेशन और ये सब कुछ बहुत नीडेड है। हम लोग जिस तरीके से भी करें, वी शुड, एक तो हमें उनसे ये पूछना चाहिए भाई हम अपने सेल्फ डिफेंस में क्या कर सकते हैं, व्हाट हैव यू केप्ट फॉर अस, हाउ शुड वी डिफेंड अवरसेल्फ, और अगर मान लीजिए हमें कुछ प्रोटेस्ट करना है तो हम किस तरीके से प्रोटेस्ट करें। तो दीज थिंग्स आर टू बी हाईलाइटेड एंड आई एम श्योर दैट this effort will go a long way in just taking the points from everyone and from each and every corner, whether it is any society, everyone should write to them. I think we can even take, if they don't listen to these written documents, we should take appointment from them that please listen to us before you finalize this document. These are there are many other points also, but I think I have taken too much of time and there are so many speakers and learned persons. So these are the main things which we should go ahead, and then there are many other points which will be brought up by other speakers.
Thank you so much, madam. Now I move to our respected Chandra madam. Please give your pearl of wisdom.
Ragini, thank you for having me here. और मैं क्या पॉइंट बताऊं, तो उषा ने सारा, हम दोनों बैठ के डिस्कस करते रहते हैं, and we have even last evening we were talking and we're discussing. I think she has cleared out all the points. My only concern is कि किसी प्रोफेशन में कभी कोई ऐसा सुना नहीं कि जिन पर कंज्यूमर लगे, जिन पर एक्शन लिया जाए, इनको ये करने से रोक दो, इनको वो करने से रोक दो। और वैसे दूसरी तरफ हमें कहा जाता है कि डॉक्टर ही खुदा है, डॉक्टर ही सब कुछ करते हैं और डॉक्टर पे ही सारी जिंदगी चलती है। डॉक्टर्स ने ही नेशन को बचाया, कोरोना से बचाया, इससे बचाया। So why all that only on us? Because I think the opinion of majority of people is that we people are earning without any hard work. We are earning by wrong means. हम पैसे कमाते हैं, हम लुटेरे हैं और पैसे जमा करते हैं। इस व्यू से हमारे पास सारे एक्शन लगाए जाते हैं। ये मैं मानती हूँ कि अगर हमसे कभी कोई गलती होती है, जरूरी है अगर है, और हमने वो गलती जानबूझ के की है, तो हमें सजा दी जाए। हम कभी नहीं कहेंगे हमें सजा ना दी जाए, पर हम भगवान तो हो नहीं सकते। वी कैन नॉट ट्रीट ईच एंड एवरीवन। अगर ऐसा होता किसी डॉक्टर के घर में किसी की डेथ ही ना होती, कोई मरता ही नहीं कभी किसी के घर में। तो इन सब बातों को हम लोग लेके, मैं तो हर वक्त यही कहती हूँ कि जो भी घास गिरनी है, जो कुछ करना है, डॉक्टर कम्युनिटी मिल गई, उनको सारे एक्शन सब कुछ उन पर ही लगा दो। अभी ART बिल का काम खत्म ही नहीं होता है कि इनका बिल आ गया, इनकी प्रॉब्लम्स आ गई। तो हर तरफ से हम लोग को एकजुट होना पड़ेगा। इन लोग की कोई मजाल नहीं है कि कभी किसी वकीलों पर, कभी किसी इंजीनियर्स पर, कभी किसी पर कुछ लगा सके। सिर्फ ये डॉक्टर्स को सबसे ज्यादा वीक पाते हैं, उन्हीं पे सब कुछ करना चाहते हैं। So we should be together, as Usha said. The only thing is that we should unite. We should fight for our rights. हमसे कंज्यूमर फोरम हट जाना चाहिए बिल्कुल, बिकॉज हम उसमें आते ही नहीं प्रिव्यू में। और आई एम श्योर हमारे जितने दिग्गज लोग हैं और IMA के लोग हैं, ये हमारे पॉइंट्स को ले जाएंगे। एंड वी शुड नॉट स्टॉप एट एनी पॉइंट। हमें जितना भी आगे जाना पड़े, हमें अपने राइट के लिए लड़ना ही चाहिए। And that is what I feel today.
Thank you, madam.
Moving forward, काउंसिल्स को ही बिल्कुल अपाहिज कर दिया जैसे, भाई स्टेट मेडिकल काउंसिल को आपको जो कुछ कहना है, जैसे हम चंद्रा जी से बात कर रहे थे, आप स्टेट मेडिकल काउंसिल को अपने रूल्स रेगुलेशन बताइए, वो उसके हिसाब से वो करें। बिकॉज इस तरीके से कि नहीं नहीं स्टेट मेडिकल काउंसिल का भी करो, उसका भी करो, उसका भी करो, हमें तो फिर कंडी बना के रख दिया, बस इधर से उधर नाचते रहो।
राइट, नहीं सही नहीं है बिल्कुल।
So thank you so much. Moving forward, now going to the IMA again. सर आप क्या कहना चाहते हैं? Dr.
Well,
Arun.
very important meeting you have conducted. I think for 3-4 weeks you are acting very actively, and whatever efforts you have made and united so many people from various cities and states and from various forums, that is a very great thing. We have been trying all these things for a very long time, that a FOMA should be active and they should participate in an activity. I believe this time also the FOMA has been invited. In fact, on my personal capacity, I know so many people who were involved in the FOMA. When I was Secretary General, I have talked to them, I have given them all information that they should come on board, write down their opinion, objection to EMRB board, because that is going to be very important. And whatever we are discussing for the last few weeks, that has been very good, and the suggestions which have come from many people, and they are all of great importance, and we feel that the things which are being implemented, likely to be implemented once it is passed by Parliament, because this document has to go to the Parliament. Any changes in the rules or any new rules and regulation has to go to the Parliament as per the NMC section 58. So after this, whatever objection we are going to give to MRB board, we have to continue meeting the politicians, because ultimately it has to go to the Parliament, and there also, if at all they're not listening to us, there also we can create some kind of impact through our friends, those who are in Parliament in the both houses. That is going to be very important. One point I like to definitely say, that when we are talking about social media and the telemedicine, there is confusion. On social media, they're saying you don't do anything. And when you talk about telemedicine, they say use every social media for telemedicine. How it is possible? On one hand, you say don't go, and the other hand, you are saying use every possible social media. So these things are very contradictory at most of the places. But one thing is very clear from this NMC Act, and as well as these EMRB board regulations which have come up. They are adamant to unite all health services, I mean, all paths of medicine with the modern medicine. Because every clause which they are going to introduce, or rather they are introducing, it has got a lacuna, and they have left spaces for themselves to introduce Ayush into the modern medicine. Initially, NMC said that they'll be maintaining another register where the Ayush, after bridge course, 6 months of bridge course, will be registered with NMC. That has been dropped, but another draconian thing has come, that the community health worker will be included in a separate NMC register, though the strength of them will be 1/3. That means from one place to the other, they are trying to introduce Ayush people. So, and then another thing, the joint thing of all the systems, the Ayurvedic system or homeopathic or the modern medicine, why they are conducting joint system. Again, they are saying that we are going to create a syllabus which will include each and everything. So we have to see, and we have to concentrate on all these things. Are we really fighting with this 114 pages, or we are fighting for the NMC Act as completely? We have been fighting for a very long time. But the only thing is, through a smaller paras, through one point or the other, they are trying to introduce so many things which are going to be very harmful for the upcoming generation. And in fact, the younger generation is going to be affected very more, because they have to follow each and everything which is coming at the practice through this legislation. So we have to fight, we have to show our strength, and the way people are joining hands together to fight against at least these 104 pages, 114 pages given. is a very great thing. And if we keep on fighting and talking to everyone and sending our objection to EMRB board, I'm sure with the joint effort, we will definitely achieve something, not everything, but something which is going to be beneficial. And as far as the penalties is concerned, penalties are ultimately going to be taken into various directions through this act. They are going to charge you, they are going to penalize you monetarily, as well as they are going to punish you. And most important thing is they have to at least withdraw one sentence that temporary suspension will be given to you till the case is decided. This we are not going to accept at any cost, because this is not even legally tenable. So we have to keep in mind what is important for us and what is important for the younger generation who is going to join the profession. I must congratulate all of us, not anyone, all of us, for taking this decision to join and work together and to fight together and inform each and every member. If our information reaches to each and every member of the community, that is nearly 10 lakhs of members of medical profession, is going to be a great thing, because I'm sure everybody is trying hard. Any association will not have contacts of all 10 lakhs if included, because they are not member of each and every association. But we know people, so we have to reach to the last person of a medical profession to know about all these things and fight with us. Thank you very much for inviting me and giving me the time. And I wish that we can fight it down till we get the positive result. Thank you very much.
Thank you so much, Dr.
Thank you, Ragini. One thing I wanted to find out, have we ever tried to make the medical graduates aware about this whole thing? Because they are the ones who are going to in future really suffer.
Yes, madam.
So have you taken this thing?
Yes, IMA has got two wings. IMA Medical Student Network and IMA JDN, Junior Doctor Network. And these two association, two wings of IMA are very active, because for the last 6-7 years, they have been fighting for each and every cause. Whenever IMA gives a call for anything which is going to affect students and the junior doctors, they are in forefront. If you go through the media reports and everywhere, so they have participated in all the activities, and they are all aware about is there in the scope for them in their future. They know.
Now with us is Dr. Narendra Malhotra and Dr. Jaydeep Malhotra. Both are with us. They are the advisors to UPCOG and past president to FOXY, and I can say they are the leader and the mentor of many of us who are here sitting. I can say they have hand-holded literally and make us to come forward and work. Over to you, Narendra sir and Jaydeep madam. They are one, so I'm calling them together.
Yeah, Naren. Actually, Naren is in the car, he's traveling back to Agra, so I can't see him. Okay. Hi, very good evening to all of you. At the outset, I would say that let me start on a positive note, that this is the time when I think God has given us one of the last opportunities to be united and to back each other, so that today we should be able to achieve what may be the future, either the death or life of medical practice. When I read the NMC bill, and in fact, even all the times, and was heading organizations and also getting in touch with the government on various fronts, I always have had a feeling that we are the biggest culprits on this soil. And I don't know why, because we need to be nurtured, we need to be looked after, we need to be cared, because we are the carers of the whole population here. But unfortunately, I really have totally been unable to understand from where this thought process is coming, because we are fighting so many battles. I was going through a lot of suggestions which various organizations have given, but I'm absolutely feeling let down by our NMC representatives. I know that there are some of the leading people who are there on board of NMC who should be protecting us. who know the ground realities, because at every place, it's a huge, humongous country. And there is no AIIMS everywhere. And there is no medical college everywhere. And we, private practitioners and other medical fraternity, we are fighting 1,000 battles. It's not only the patient or, you know, there's infrastructure, there's manpower, there's electricity, there is rising, you know, inflation, and the nurses. There are thousands and thousands of problems which we are facing, and against fighting with all those, we are trying to provide the care which we feel that every person like you and me deserves. And I am absolutely feeling totally let down. I think it is it's not been thought properly, because when you read the bill, you're not even thinking what kind of an impact it will have on the general population when in one day 30 doctors will go behind the bar. Just imagine what kind of an impact will there be on the consequences, on the long-term mental, physical, emotional, financial health, not only of the doctors. Let us not even think of doctors. It is going to have a huge impact on the population. Tomorrow we are going to be ruled by a group of just few dictators, and that's not, I think we know that legal and medical and holistic, well, these were the three professions which were beyond any rules and regulations. We were autonomous. And why we are only coming under these kind of regulations? I don't mind the regulations, but they have to be properly thought of. And I think we should have been the part of. Or now, even when the ART and the surrogacy and all those bills were coming, we are decreasing corruption at one end, but all these are going to increase the corruption. On one end, we say Ayush is equally capable of treating. On the other end, you are saying that the Ayush cannot be employed by an allopathic doctor. Why? Why this division? I think we need to be looking at a collaborative effort. If they can do certain part well and we can do certain part well, I think the government should have had a cohesive thing. But if we are not looking at all those things, we should at least look at the best of the population which is there. And because I know that, you know, some of us may not agree with a few things which I am saying, but I'm not saying because I'm a medical professional or an allopathic person. I'm saying as a patient, as a beneficiary, because it makes this affordability, availability even far reaching than what it is now. It is going to kill a lot of people sitting on the periphery who are serving without any this thing. And most of the times when we say, where is the anti-quackery bill? There's nothing which is happening on ground. Why are all these regulations only on qualified people? Why we are not looking at the food adulteration, which is killing many more people than the doctors killing anyone? I think we need to raise a voice against all. And it's high time that we get together and show ourselves as a united force, which unfortunately we have never been able to do. And that has been our weakest point.
Thank you so much, madam. Thank you so much. Dr. Narendra Malhotra has come back. NM sir, over to you.
So sorry, I got disconnected because I was traveling in the car from Delhi. I just reached home, so I've connected with my laptop. Now, see, we have already pointed out all the various things and points which we should be doing. The time now is for action. And the first action is that whoever is making these bills and whoever is doing, so we must have a high power committee which should be immediately taking appointments from the Health Ministry, Health Secretary, Law Ministry, Law Secretary, even try to get an appointment with the Home Minister if possible. That is our number one thing, and the letter should go to them for appointment. And then secondly, we should, in our cities, should approach our Member of Parliament and show him what is wrong in this bill. So once it comes in the Lok Sabha or the Rajya Sabha, wherever it's going to come first, these people should stand up and raise voice for us. Like Dr. Kakoli Dastidar raised for the ART bill. She spoke so strongly and that MP from Chennai spoke so strongly for us, but still it got passed without. And then our committee was there. Dr. Jaideep was there in the parliamentary committee. She placed with slides to those 20-30 MPs that this is wrong with the ART bill. Similar audience, and we should be addressing the parliamentary committee, parliamentary board, all our MPs, and try to meet the ministers and the bureaucrats to take up points. All the points, I agree. I'm not going to repeat what Chandravati, Usha Sharma, Jaideep have said. I have already compiled the point and sent to everyone. We will make a final draft, which will go on the emails, but let's take appointment and meet these people.
Very important point. Now that you have given a direction after this meeting and sending the till 22nd, whatever email we will send, then we should have a delegation of a high-level committee to meet them. So now we have a president of two main association with us today, Dr. UPCOG, UPCOG Dr. Tarni Taneja, and Dr. Pradeep Singh, UP IMA president. So we want to listen their views also, Dr. Tarni and Dr. Pradeep Singh.
A very good day, Dr. Ragini and everyone present here. My greeting to each and everyone. Actually, my net is very interrupted. I don't know why. Dr. Ragini, first of all, congratulate you for taking such an initiative for such a very important issue. Even as Dr. Naren said, even I thinking there is nothing like doing all these. Don't think we are wearing all our members, but we have to sit our delegation with the main authority who are making the bill. It seems they are the biased with the modern medicine. If they don't want the modern medicine, they should suspend the license of each and every one. So why they are creating so much nuisances? Who can read 104 pages and comply them? So if they want to put in the, I think they want to, stop the modern medicine. So we have to sit face to face and talk to them what they want to do. We cannot accept this NMC. Who can put all 3 years record of OPD? Who can put all these records? And why should we comply all these 104 pages? Nobody in the advocates, engineer, all public sectors, nobody is having the regulation. Why we are having the regulation? So thank you so much for giving the opportunity. The main thing is we have to go with the delegation and sit with them and talk.
So we have to be very, very fast. Over to you, Dr. Pradeep Singh.
Thanks, Dr. Ragini, for inviting me in this important session. Nowadays, our profession is passing through a very difficult time. Nowadays, government changing rule on day basis. NMC new draft is also give difficult time towards our profession. Under new draft, our local CME will lose importance. Now, state will conduct the CME and credit hours will be also given only by state level, and for every CME, there will be an inspector, and it will be very difficult to conduct CME in whole state, just like UP is a very big state, so it will be difficult to manage. Other issue is generic, non-generic. I think I've seen in practical life, generic drugs are more costly. And I don't know any politician or bureaucrats want to eat generic drugs. They are only for people, poor people. Because it's true that generic drugs are not effective. Is it true? Good brand always do better. Other issue, today we have seen on social media, off duty, doctor will not take alcohol. So this is a loss of our personal freedom. No one can stop our personal freedom. And I think at last we should ready for action. Or action come only through IMA. We should plan indefinite strike. And I think if we'll block the emergency services, government will shake in within an hour. So we should be ready for strike. If government is not ready to listen, then we have to do our action. ज्यादा गड़गड़ाने से कोई काम नहीं चलेगा, स्ट्राइक से ही काम चलेगा इस म्यांमार। तो यही हमारा वो है, बाकी तो हम कहते रहेंगे, कहते रहेंगे, ना सॉल्यूशन निकलता है तो पूरा नहीं निकल पाएगा। स्ट्राइक के लिए ही तैयार रहना पड़ेगा, ये हमारे पास है।
Very valid point which is raised by you from Malhotra sir. First a delegation, first these mails, then the delegations, and if it is nothing happen, we have to come on the road. Otherwise, also we will on the road.
Road is not alternate. We have to stop our work.
Yes, that is why I mean on the road,
including emergency service.
Stop
OPD
everything.
is nothing.
But
Stopping of OPD service is nothing.
Again, unity and solidarity.
Yes, madam. Yes.
Very important.
So now what I can see, our two teachers, very great teachers, Dr. Vibha Mishra and Dr. Anuradha Khanna, both are there. Because maybe if I will miss someone, please don't mind. I will continuously scrolling and seeing everybody's name. So Madam Khanna and Madam Mishra, we want a few pearl of wisdom from you. मैडम अपने को अनम्यूट कर लीजिए अनुराधा मैडम।
मेरा सबसे नमस्कार और स्पेशली रागिनी, आपके इस एफर्ट्स के लिए आपको बहुत बहुत बधाइयाँ। मैं हिंदी में ही बात करूँगी। ये आपने इतना सेंसिटिव मुद्दा रेज किया है जो इसको कि सब सुनते तो हैं, उस पर इम्प्लीमेंट नहीं करते हैं। आज आपने सबको इस फोरम पे इनवाइट किया, बहुत अच्छा किया और सब बहुत अच्छे से कर रहे हैं। हमारे चीफ पैट्रन मैडम शर्मा, पैट्रन मैडम चंद्रावती और IMA प्रेसिडेंट, सभी के वक्तव्य बहुत अच्छे हैं। बस यही है कि इसको कैसे किया जाए, दैट इज द कोर थिंग, हाउ टू प्रोसीड। जैसे कहा भी किसी ने, पहले मेल करिए, फिर आप मिलिए और फिर अगर नहीं तो स्ट्राइक पे चले जाइए। ये सब ध्यान में रखना पड़ेगा कि एक्चुअली हमको चाहिए क्या, व्हाट वी वांट एक्चुअली इन रिगार्डिंग ईच एंड एवरीथिंग। पेशेंट कैसे देखें, रिकॉर्ड कैसे मेंटेन करें, अगर कॉन्फ्रेंसेस करानी है तो कैसे कराएं, कहीं कॉन्फ्रेंसेस में जाना है तो कैसे जाना है, क्या करना है, कितनी कॉन्फ्रेंसेस होनी चाहिए। एवरीथिंग इज वेरी वेरी इंपॉर्टेंट। जस्ट टू से everything is right, everything is wrong, I am not going to say like this. और एजुकेशन बहुत इम्पोर्टेंट मुद्दा है कि हाँ, आप आयुष, होम्यो और मॉडर्न मेडिसिन को एक कैसे कर सकते हैं। अगर एक ही करना है तो कंपटीशन भी एक ही कर लीजिए, क्या फर्क पड़ता है, कहीं भी किसी को डाल दीजिए, क्या फर्क पड़ता है। तो अगर वहाँ फर्क पड़ता है तो फिर आप एक कैसे कर सकते हैं। ये सब बड़ी सिंपल बातें हैं, इसको सब जानते हैं, लेकिन फिर भी पता नहीं क्यों हम मॉडर्न मेडिसिन से सबको प्रॉब्लम ही पड़ी रहती है। तो दीज आर द थिंग्स। और ऑफ कोर्स MBBS करके कुछ बच्चे रह जाते हैं, तो वो आगे क्या करें। हर कोई तो कंपटीशन में आगे नहीं बढ़ जाएगा, हर एक के पास पैसा तो नहीं होगा कि वो प्राइवेट को भी अफोर्ड कर ले। तो IMA मिलके बहुत अच्छा काम कर रही हैं और उसको आगे काम करना चाहिए और हम सबको आगे प्रोसीड करना चाहिए। तो वट एवर कम्स आउट आफ्टर दैट। और अभी जैसे मुझको नॉर्थ जोन करना है वाराणसी को, और हम लोगों को बिना अभी तक तो किसी ने भी फार्मा सपोर्ट से कुछ किया ही नहीं है। तो अगर हम कुछ फार्मा सपोर्ट नहीं लेंगे, खाली सेल्फ करेंगे, तो फिर ठीक है, फिर उसी हिसाब से करके देख लिया जाएगा। और अगर फार्मा सपोर्ट लेते हैं तो उसमें बुरा क्या है भाई, कुछ भी कोई करता है तो वो एक कॉल करता है, इनवाइट करता है सबको, तो उसके सपोर्ट से ही आदमी काम करता है। अरे आप जो है इलेक्शन लड़ते हैं तो आप भी तो अपना फंड रेज करते हैं, तो अपना इलेक्शन लड़ते हैं, तो हम अपना फंड रेज करके कॉन्फ्रेंस करते हैं, इसमें बुरी बात क्या है। सो दीज आर माय सिंपल इश्यूज जो मैंने अपनी हिंदी भाषा में बात करी। थैंक्स लॉट राजनीति।
इलेक्शन लड़ते हैं तो फंड
रेज करते हैं।
मैं क्या डॉक्टर जयेश लेले सर को मिस कर रही हूँ क्या? उन्होंने ज्वाइन किया था, जयेश लेले सर।
डॉक्टर राजीव गोयल हैं।
मैं अपना रागिनी,
हाँ जी
डॉक्टर रागिनी, मैं कुछ बोलना चाहती हूँ।
हाँ जी विभा जी, आपका तो नंबर ही है इसके बाद।
नहीं, नंबर तो सबका ही है। दो बातें कहना चाहती हूँ। ये जो बिल है, ये 2002 के मेडिकल काउंसिल ऑफ इंडिया का एक्सटेंशन है, एंड दैट टू ए बैड एक्सटेंशन, वेरी वेरी बैड एक्सटेंशन। प्रॉब्लम क्या है कि हम लोगों ने उस बिल को अच्छी तरह से अपोज नहीं किया, लेकिन अब ये करो या मरो की स्थिति है। अब हमें बहुत अच्छी तरह से इसको अपोज करना है। इसमें सबसे गंदी चीज क्या है, वो पुराने बिल को तो उसको इंक्लूड ही किया हुआ है, एक रेगुलेटर बैठा दिया है। रेगुलेटर शुड नॉट बी देयर। रेगुलेटर क्या करेगा? इट विल बी लाइक ए सब इंस्पेक्टर ऑफ योर थाना। यू हैव टू प्लीज हिम एंड सेटिस्फाई हिम फॉर एवरीथिंग। पहले थाने को सेटिस्फाई करिए, तब आप आगे बढ़िए। ऑलरेडी कोई भी जनरल प्रैक्टिशनर या मेडिकल प्रैक्टिशनर या ऑब्स्टेट्रिक गायनी प्रैक्टिशनर 34 जगह पर अपने टैक्सेस देता है। इन टैक्सेस ने, इन बिल्स ने मेडिकल एक्सपेंसेस को इतना बढ़ा दिया है कि वो जनरल पब्लिक की पेट से बाहर हो रहा है। और हमको मेडिकल सर्विसेज को सस्ता करना है, लेकिन सस्ता नहीं हो रहा है। इतने सारे रेगुलेशन आप कहाँ से देंगे? It is your pocket which is paying, and finally it is patient pocket which is paying. अगर आप उसको ठीक से रेगुलेट नहीं करते हैं, आप अपनी लैक्यूनी को डॉक्टर के ऊपर क्यों डालते हैं? आपको उसको संभाल के चलना चाहिए। रेगुलेटर शुड नॉट बी देयर. I should be totally separate from the medical. Then there should be personal freedom. Then there should be this maintenance of OPD record for 3 years. Medico-legally, you are supposed to give in 3 months' time the notices to the doctor. Why 3 years for OPD? What is there in 3 years? आदमी सो के जागेगा? नहीं. It is not like that. You have to make a single bill and single very clear-cut bill. No gray areas. There are so many gray areas in this bill. So many experts in this panel are there. I think if they go through, and they have gone through very well, and then those very well thought processes should be implemented, and we should make a note of it, and gray areas should be deleted from this NMC bill. This bill is very, very bad, and I say hats off to Ragini and all those 28 people who are here on the dais today, that they will make a good effort to take the things to the upper level. Problem is at legislation. They do not understand. They have to see the larger public. And you may shout anything, you may do anything, you may do anything, but they will do whatever you like. You have to force them to do the things what you want. Sangheya Shakti, matlab unity में power है. आप unite करिए, power आपके पास आएगी. That is what I want to convey. Sangheya Shakti.
Thank you, thank you. Now we have Dr. Rajiv Goyal, Secretary IMA UP State. Over to you, sir.
Thank you, Dr. Agni, for inviting me to this forum. And I feel most of objections till now have been discussed, and they all are valid. But one thing is in my mind: whatever you discuss, whatever you write, whatever mail you send, government is not going to do anything. Yes. They are admit they'll put strange rule against us, whether it is MCI, whether it is Clinical Establishment Act, whether it is NABH, or now this NMC. All rules are created just to create problems for us, or we keep crying and saying this and that, but they never listen to us, and they never changes the rules. Still, it is our duty that we should fight, and we should put our points to the government. Maybe they will respond it, but they are very strange people, and they want to have some strong crops on us so that we cannot fight with them. So, ma'am, मैं समझता हूँ कि जो हमारे बीच में अभी सबसे इम्पोर्टेंट पॉइंट आए हैं 2-3, उनमें एक तो ओपीडी की, टू कीप द रिकॉर्ड्स ऑफ ओपीडी फॉर 3 years, वो बहुत ही स्ट्रेंज है. You can keep the indoor records, although indoor record भी इंडिया में at least in poor places, where low sugar from it people come and they get treatment and at low cost, there a lot of records are generated. and those hospitals are not fully competent to keep all these records for a long period. But it is further difficult to keep records of OPD for 3 years, because every paper you have to scan, every report you have to scan. And although we are following the UHID number, most of places in NCR and other important cities are following UHID number. You can keep at least some of the record, but not all the records. And somehow a patient comes through court and says, show me all the records what you have given me in OPD. Then we'll be in troubles. And patient is supposed to keep their records for their safety and for their further medical history. So why should a doctor save all this record? That is more important. Second thing has been discussed very well about generic and branded medicine. I think if we write the generic medicines, the ball will go into the hand of the medical store people. Now they will think where we have got high margin, which medicine we can give. So now we are not deciding which medicine to give. The medical store people will decide what medicine to give. By generic name, they can give branded medicine also. They will say the patient has demanded a branded medicine. That is why we have given the generic medicine. And if you see that these generic medicine carry very high price tag, they come at very low cost and then they are sold at very high price tag. Even the branded medicine does not have that much of the high price tag. So why doctor cannot decide? We know which medicines are cheaper, which medicine are perfect for our patients. Why this is given free hand to the medical store people that they will replace our medicine by any brand, any medicine, whether it is substandard or. And third thing, we cannot attend those conferences which has been sponsored by pharmaceutical companies. If they will not sponsor, then who is going to sponsor? Will government sponsor? Or how come IMA or some other body is so strong that they will organize conference without any financial burden? And if we have to pay all the money, we have to pay from our pocket. So it will be very, very difficult for us to attend and get the 30 credit hours in 5 years. So ma'am, this all what I want to say. I think most of point has been raised and most of time we have raised are totally absurd. But I am doubting that government will listen. If government will listen, Dr. Pradeep Singh has raised proper point. We have to struggle. We have to come forward to struggle for our cause. Thank you very much.
Thank you. Thank you so much. We have another senior teacher with us, Dr. Radha Jina. Madam, over to you.
Thank you, Ragini, for bringing this important forum for discussing NMC bill. I have heard all my previous speakers and I am fully agreed that this bill is nothing but just to harass the doctors. We doctors are easy target for everything. Now, Dr. Goel has raised very important 3 points, which I was also trying to raise, and that is the OPD record for 3 years and generic medicine. How can we write generic medicine for everything? Because we cannot write just a generic medicine and the pharmacist may give any medicine, so that it will not be in our hands. And all the VIPs, they don't need the generic medicine, they need a good medicine from a good company. So will not be able to write this and they will not be satisfied. As far as the conferences are concerned, we all know that these all conferences are with the help of the pharmaceutical companies, and we cannot do any conference at our own expenses. It will be so difficult to do any CME or any conference, and we'll have to do our own researches. We will have to do our own, and we can say we will have to go for internet and everything, which we are doing time to time. So these all जो lacuna है bill में, that is very, very bad, and we have to fight for these, and all our stalwarts, they have to make a committee and they have to fight सामने, not by mail or by, no, otherwise they are not going to listen anything. So thank you so much.
Thank you, madam. We have Dr. Rajna Khanna, Dr. Rukma Indani, and Dr. Yashodhara Pradeep. We have three senior people with us, Dr. Rinna Khanna, Dr. Rukma Andani, and Dr. Yashodhara Pradeep.
Yeah, a very good evening, everyone. Actually, I'm in Mumbai currently in the cab. So I just wanted to say one thing, that what we really lack, is unity. And because of this lack of unity, and we always think about the patient's welfare. Whenever we go on strike, we are always aware that the patient may not suffer. So as a result of this, we never come out strong and united. And this NMC bill is going to make the Ayush doctors so powerful, and we qualified doctors have to face all the music all the time. So I think this is really very unfair, and we really should express our displeasure, and something should be done about it. And along with IMA, I think we can manage it. So this is my take on it, that we should go very strong on this subject.
First of all, I congratulate Ragini for taking this issue, which is very important for us, because we are just doing studies and spend more life years in education, in reading, in MBBS course, then PG and all that, 8 to 9 years. And then we are being treated equal to Ayush. Why is it so? And this bill is and I don't agree with this bill, because this is being governed by the various government facility persons, which they don't know the good reality, the basic reality of our doctors who are working at base root levels. And I know that we are the doctors, we don't have the solidarity, we don't have any unity until unless we are united and you represent to government and talk to them for this representation. And I don't think that this bill will work so long, but we know that these official bureaucrats will not understand our problems, and then they will not agree later on. Number two, for OPD records. So that is, if the doctor is very busy and like a private practitioner, how can they maintain a 3 years record? And they have to employ 2 or 3 person to make the record. So that is more expense to the doctor. And number 3, generic medicine, which has been already covered. Because suppose we write one medicine that contains 5 salt, how we will decide that which medicine we have to write? And it will only the pharmacist or the chemist will decide that this is the drug which is to be given. And that is the more corrupted area in the field of medicine. And we are the very weak personality which are easily governed by these bureaucrats. And we have to just go them and talk to them and represent our views to them. So we are doing 8 to 9 years course, and the views, they are not doing this course, and they are being treated equivalent. And they don't have the knowledge which we are having during MBBS, the course, during MS, during our post-graduation. So we have spent 8 to 9 years in this study. So I think most of the points, they have been covered by so many people. The main point is that we have to show our solidarity, because we are the most weak and neglected society of population in India. And this should be covered, and this we can correct it by the solidarity and unity. Until unless we unite, nobody will listen to our voice. So that's why to say these 2 points, which have already been covered, Ragini. So thank you very much for giving me this opportunity. सबको कहते हैं इसने क्या किया, ये तो पढ़ लिया, बहुत पैसे देके आ गया, प्राइवेट में आ गया, डोनेशन दिया, इसकी क्या नॉलेज होगी? पर मेहनत तो कर रहा है ना, आयुष के बगैर तो आयुष के बगैर तो नहीं है ना वो इक्विवेलेंट. So that is the main thing which they don't think, and they are making Ayush equivalent to MBBS and postgraduate doctors. So thank you very much, Ragini, for giving me this opportunity.
And the way you are collecting the data, I would request you to kindly summarize all the suggestions and send it. And at the same time, keep on appealing about the emails. A lot number of emails will make a lot of difference. Maybe that in one email somebody gives 1 point or 2 point or all the points, Not necessarily that they'll consider all the points, but at least we'll be hammering them and hammering it the best way. And by this way, we are going to create a awareness among our people, and at the same time, strong resentment about the things they are handling, we people. And we strongly demand that such sort of thing, or all bookish things, the bureaucrats have dictated into the regulations. These are not acceptable to all of us. And because such things are there, and we fume up and we get heated things during our conversation. It is a not natural phenomena. The way we get heated, the way we keep on writing to them, we will have to come on the road. I again repeat my thing that not that I'm a extremist, but if the things are not hard from us, we should be ready to agitate. We should be ready to come on the roads and fight it out, because it is concerned with our future generations. It is concerned with us, and is concerned with our profession. It is a, if you go through the 104 pages, you must have gone, all of you must have gone. Every line is against we people. And this was existing earlier also in MCE also, but now also they have done it in a more stronger way. They are trying to hero us from all the sides, which is not acceptable to us. We are London people, we are qualified people, still they are doing anything. You must have the letter from the IMA department, what rubbish they have written, that it is not binding on them, NMC not binding on them, and everything is binding on us. So that is the thing we have to fight out, and all this have been received by now, and kindly go ahead. We are with you as a person, as an individual, as past president of the state of Haryana, and every day I keep on putting the bells and keep on.
Thank you so much, Dr. Karan. Over to you, Jyoti, my co-chairperson for this show. Please carry on with the part of the discussion part of Dr. Nagpal and Dr. Sonia Malik, the two lectures which we have kept to discuss in detail the draft. Then we go for the open discussion with the other faculty. And by the time Dr. Ele will also join and Dr. Ravi will also join.
Thank you so much. Thank you, Dr. Ragini ma'am, and thank you all our guests, our invited guests, our special guests, our chief guests, who have taken our time and who have given their precious viewpoints on this discussion. And now we have Dr. Neeraj Nagpal, who would be talking to us about professional conduct, responsibilities, duties, and rights of RMPs. So once we listen to him, and then again we will continue with our discussion. We will take the comments of our special guests and people who still we have to listen to, and then we frame the final verdict after that. So over to Dr. Nagpal sir to give us your viewpoints. Thank you.
Thank you, Dr. Jyoti. Thank you, Dr. Ragini, for having me here. Now, these 104...
Yes, sir. Slides are visible.
These 104 pages of regulations which have been published regarding how I should conduct myself, what my ethics should be, what my duties are. It's interesting, but I think slightly incomplete, because it has not mentioned whether I can wear red socks, whether I can go on a vacation and enjoy myself, or whether I can buy a car more than 10 lakhs also. So in that way, it is incomplete because it is only 104 pages. We could have increased this to some extent. When we talk of ethics, what basically these regulations are undertaking, the Hippocratic Oath always comes to mind. However, in our Indian context, the important thing is what the Indian Medical Council Professional Conduct, Etiquette and Ethics Regulations brought in 2002. We have been speaking repeatedly regarding National Medical Commission Act of 2019. Please understand, the National Medical Commission Act has already been notified. It is operational since 2019. What we are here to discuss today is the National Medical Commission Registered Medical Practitioner Professional Conduct Regulations, 2022 draft, which has been placed in the public domain. This is something which is of importance to us because what was 15 pages earlier in 2002 has now been increased to 104 pages. And as I said initially, probably it should have been much more because keeping the intention of the government in mind, this seems to be a very liberal interpretation of what exactly they want. If I look at the entire draft, this draft is designed so that not a single doctor can escape being punished for misconduct at least once in his professional life. Each one of us will have to face punishment for misconduct at least once in our professional life if these professional regulations come into play. However, I have certain suggestions to those who wish to give suggestions to NMC. On behalf of Medico's Legal Action Group, around 15 days ago, we have already sent our suggestions to the National Medical Commission. We have also placed them in the public domain so that people can use it, add to it, delete it. Because every time I'm sitting with different organizations and I'm trying to discuss, even every time I'm reading our own suggestions, which we had prepared after 10 hours of intense discussion between 3 or 4 of us, the fact still remains, every time I read it, I find we have missed out certain point. Every time I feel this could have been improved. And what I'm going to suggest today, you may agree, you may not agree, but kindly, when you give your suggestions, please have these 4 principles in mind. Number 1, forget turf wars. हिस्टेक्टमी गायनेकोलॉजिस्ट ने करनी है, सर्जन ने कर दी, एनेस्थीसिया एनेस्थेटिस्ट की जगह पीडियाट्रिशियन ने दे दिया, सर्जन ने लगा दिया, प्लास्टिक सर्जरी, ओरोफैरिंजियल सर्जरी, ENT सर्जरी. My point is, when giving these suggestions to the NMC, please forget about turf wars and have the interest of the entire community in mind. Number 2, focus on lowest common denominator. Lowest common denominator for all of us, whether we belong to FOGSI, whether we belong to IMA, whether we belong to API, whether we belong to any organization, is MBBS. So please keep the focus on the lowest common denominator. If you are giving suggestions, keeping the interest of the MBBS doctor in mind, you will not go wrong. Number 3, focus on doctors who are working in periphery, where basic amenities like electricity, water are issues and not internet connectivity. So these are the principles, and of course, focus on the youngsters joining practice. I mean, an MBBS doctor can be 50 years in practice. So I have said we should keep a focus on the MBBS doctors, but we should also keep in focus the youngsters who may be specialists, but who are freshly joining practice. So their interest has to be kept in mind when we give these suggestions. And if we keep these principles in mind, we cannot go wrong. I agree totally and 100% with what was said earlier, that the definition of modern medicine is something which needs to be looked at very, very carefully. The entire definition which has been given can as well copy pasted in the Central Council of Indian Medicine Act, and immediately whatever they teach and whatever they practice will become modern scientific medicine. If you go through, you read the wordings that is written, it's a healthcare discipline that involves scientific understanding of disease process using rational evidence-based treatment methods. What do you mean by this? Swami Ramdev says he has understanding of disease process and uses rational and evidence-based treatment methods. Is what he providing modern scientific medicine? Similarly, I can give arguments. There is only a single line in this definition which meets the criteria, and that is modern medicine has international uniformity. But what we have suggested is, please extend this line to say among majority of the countries in theory and practice. Not that Chinese medicine, which is an international, which is international in nature, is brought to India and some kind of research is done and started practice. That does not become modern scientific medicine. So what we have suggested is modern medicine has to have international uniformity among majority of the countries in theory and practice. And number two, very, very important, the last line, it however does not include Ayush systems of medicine. This line has to be added. I would have much better preferred if they had simply defined modern medicine as what is being taught in MBBS. However, they are allergic to the term MBBS, and they would much better prefer somehow for the Ayush doctors to get into the modern scientific medicine, and this is one of the ways to do it. Similarly, definition of RMP means a person whose name is either registered in state medical register. Now, please understand, Maharashtra government has said that Ayush doctors can be registered in the state medical register. We do not want this uniformly applied across the nation. So we need to enter over here means a person who's qualified in modern scientific medicine and whose name is either registered in state medical register or Indian medical register. So who has to be qualified in modern scientific medicine? Then comes the question of prefix, suffix, and modern medicine. What has been suggested is, yes, they have recognized that there are all kinds of doctors, and for modern scientific medicine, they have suggested a prefix of medical doctor. We did not have any discussion on this issue, maybe because this is a soft point. I frankly do not care whether you call me Neeraj Nagpal MBBS or medical doctor Neeraj Nagpal or Dr. Neeraj Nagpal. The point is, regulations of modern scientific medicine, the National Medical Commission Act cannot ask the Ayush to start using as Ayurveda Charya or Vaidya or Hakim. They can only guide what MBBS doctors should be doing. They cannot guide, they cannot dictate what others will be doing. So this is something which is an open for discussion, and some kind of a consensus has to be reached on this issue. Another point which was raised was whether fellowships in various specialties or subspecialties can be used as a suffix to a person's name and qualifications. So we are suggesting that maybe memberships of societies should not be used, but fellowships of various specialties and subspecialties may be used. However, I wish to qualify here, there was a suggestion that only fellowships which require a structured training program. But please remember, to senior doctors in particular associations, based on their contribution, based on their experience, the association or the organizations elect certain members as fellows. They are not going through a structured training program now. So I will disagree with the previous speaker on this issue that a structured training program is necessary, but if it is a recognized association of a specialty, it is a recognized organization which is representing a specialty, and they are giving fellowship to a particular person, I think that should be permitted to be used as a suffix. The most contentious issue is who is a specialist. Obviously, an MBBS doctor with no training of any kind in any specialty cannot claim to be a specialist. Can an MBBS doctor who has worked for 5 years, let us say with a pediatrician or in a department of pediatrics in a government medical college in a non-PG state, does he become a specialist in pediatrics? Remember, Indian Evidence Act says that a person who is trained and experienced, it does not use the word qualification, is an expert, and he can go to court to give evidence in favor or against a pediatrician without actually having a qualification himself. But he is an expert in court, however, he is not a specialist outside. This is the dichotomy. We need to settle this. We have umpteen MD medicines, cardiologists practicing across the country. We keep it under the carpet. It does not mean the problem does not exist. The Clinical Establishment Act has solved the problem to some extent. What they have said very clearly is that if a person has received 6 months training in an institution which is otherwise NMC recognized to provide postgraduate qualification or a super specialty qualification in that specialty, then that person can do the work of that super specialty clinic or a hospital. Like for cardiology, for gastroenterology, for neurology, they have specified that an MD medicine with 6 months training can be there to do certain procedures and whatever work is required for that super specialty. So this example is already there. Another thing, in the army, we have 2 systems of specialists. One is a qualified, one is a graded. So there are graded specialists who work as specialists, who are recognized as specialists, but who do not have a required qualification. Their pay scales may be different, all that may be different, but the fact remains these systems already are in existence. And I know this is a contentious issue, but in this audience, I will strongly like to request you to please stop and consider that gynecologists who today are practicing infertility, tomorrow may become non-specialists because an MCH in infertility has been started somewhere. This super specialty culture, we have to check somewhere, and this is the appropriate place where this issue should be raised. Then is the issue that every RMP shall practice a system of medicine in which he has trained, and he should not work with a person who is not qualified in modern scientific medicine. This should be added in section 4D. If a person is qualified in more than one system of medicine, the section 4F says he should not be permitted to use either. He should be forced to select one and be registered in that. I personally disagree with this, because if a person is qualified in 2 systems of medicine and he wishes to practice both the systems of medicine, if he goes to court on his right to practice his profession, I'm sure the courts will be siding with him if he is properly qualified for both. Yes, we can say in one single patient, you should not be using 2 systems of medicine. But then again, this is open for discussion, and whatever the consensus is can be sent as a request, as our suggestions. The issue of continuing professional development, this is the most contentious part. But what is more important is registration of an RMP in one state. And what it says is, when an RMP wishes to practice in another state, due to transfer or work or residence, should inform the state medical council and apply for license to practice in that state. My issue is, there are many places which have contiguous boundaries. NCR Delhi is one. A doctor may be practicing in Haryana, he may be practicing in Delhi, he may be practicing in UP. Chandigarh is another. A doctor may be practicing simultaneously in Punjab, Haryana, Himachal Pradesh, and UT Chandigarh. The issue is, we have added over here to clarify this, that as a central registration number has been started, RMPs who wish to practice in more than one state should apply to both/all concerned state medical councils, informing them of existing registration and request for additional registration. State medical councils shall provide the license to practice after proper fee has been deposited within a period of 15 days, after which RMP would be deemed to have been given the license. The unique registration number of the RMP may be linked with the state medical register rather than allotting 2-3 different registration numbers. This is important because somebody has raised this issue that you have one registration of a vehicle across the country, and that registration itself identifies which state you belong to. We do not want a state-specific registration. Yes, you want us to register in different states, we understand. Ideally, it should have been, if I am registered with State Medical Council and that State Medical Council sends my registration details to the National Medical Commission, I should not need, these are not separate countries that we need to take separate licenses. But agreed, health is a state subject. I understand the law behind it. But the point is, in principle, we have to get this thing introduced that a doctor can legally be practicing in 2 or 3 states, and he should be permitted to do so. Extension of this issue is also when you are going to a different state to to attend a conference and you perform a surgery over there for the audience to see. You are not registered in that state, medical council. So these are issues which need to be addressed, and this is the right place to address it. Section 6 is right to remuneration of an RMP. I have cancelled the portion of an RMP. I have said point number 6 is rights of an RMP. The entire 104 pages has 6 lines on the right of a doctor, and these are regarding the fee he can charge. What we have suggested is we make this 6th point rights of an RMP, add over here right to safe work environment, including right to be protected by the employer, government of the day against violence, right to limit working hours as per individual preference, right to proper hearing and justice, right to practice profession unhindered without over-regulation and or judicial adventurism, right to stop treating a patient if the patient doesn't pay professional fee, if patient or attendant consult another doctor, patient or attendant do not cooperate or follow doctor's instructions, or if the doctor is convinced that the illness is fictitious. We should also have a right to abandon the patient if he threatens, assaults, or indulges in violence. We should have the right to self-defense. The rest of the citizens of the country have it. Why should we not? Right to privacy, right to protest peacefully. Why right to privacy is important? Ahead it is coming that when you write a prescription, you have to write your mobile number. I'm sorry, I do not want to share my mobile number. This can be told to the patients that yes, in case of an emergency, you should approach this particular hospital in the emergency, or this particular number you should contact, and they will tell you what is to be done. But I cannot be legally statutory requirement that I give my mobile number on the prescription is something I will object. Right to protest peacefully. Medico's Legal Action Group had taken a case from the Lucknow bench of Allahabad High Court, and where KGMC doctors who were protesting were fined 25 lakhs each, and the criminal case was suggested to be filed against them. And this right to protest peacefully is only not available to doctors. We have taken up this in a special petition in Supreme Court, and the case is pending over there. I don't expect too much, but the fact is we need to ask for our right to protest peacefully. Right to speedy trial, right to freedom of expression and speech, right not to be arrested in a routine manner for allegations of negligence, right to equality and non-discrimination, and right to cross-examine a person who has filed an affidavit against us. In fact, we should add over here, which we have not added in our original draft, is a right to protection from legal suit in case of action having been done in good faith. I think if we can add this right over here, a lot of our problems can be solved. I was listening to the previous speakers. We are confusing National Medical Commission Act with these regulations. We are also confusing Consumer Protection Act 2019, which is also already notified, already applicable. So in the regulations of an NMC Act, you cannot introduce something which is not relevant. That is, the Consumer Protection Act does not come into the picture in this. Similarly, Section 7 is prohibiting soliciting of patients. What we have suggested is add over here hiring of third-party agents, keeping in mind Plexus MD and so many other platforms which have come in, who guarantee you that they will increase your patient. They want some cut out of the consultation fee and various kind of systems. So I think that this probably should be banned. Section 10 says we should not issue certificates of proficiency in modern medicine. Yes, this exception is there for bona fide student. What if a BAMS doctor becomes a bona fide student and pays fee to me? Do I train him? He becomes a bona fide student, but he does not become an eligible student. Because for eligibility, he has to be either a nurse or a pharmacist or an MBBS doctor. So we have added this word eligible to cut the point where Ayush people can be trained as per these. Where restriction of advertisement is mentioned, I always say on a Saturday, please give an advertisement that you are going to resume your duties from Monday. You can give this advertisement as many times as you want, because you are on vacation on Sunday and you are going to rejoin duty on Monday, and this is permitted that when you are resuming your practice, you can give an advertisement. Don't tell any state medical council that I advise this on this platform, but if a resumption advertisement is being given, there is nothing wrong in that. Then is the issue of what are the responsibilities of RMP regarding sale of drugs. Here, what we have suggested, you add drugs and disposables provided by RMP to his or her own patients should be billed separately in the final bill. Pharmacology being part of MBBS course, RMPs do not need separate drug license for maintaining pharmacy within their clinical establishment, which provides medicine to their own patients only. This is a big problem across the country. Drug inspectors come, they issue a notice that you do not have a drug license, when actually Drugs and the Cosmetic Act says very clearly a doctor can dispense medicines. The issue arises for inpatients. When I give my surgery patients or whichever patient has been admitted medicines from my side, today they are all insurance patients. They say, Doctor, wo medicines ka details break up de dijiye. The moment you give that, it is assumed you have to have a drug license. Now there is the problem, and this is not clarified anywhere. Number of court cases are going on. I think one case was lost in Kerala. Punjab and Haryana High Court, another case is going on this issue. So if we can introduce this fact over here, this will save a lot of heartburn to a lot of doctors. We have also mentioned, because now Clinical Establishment Act says you have to maintain outpatient and inpatient records. That is already notified. So getting this thing into this dispute, whether OPD records should be maintained or not, I think we have already lost the bus there. Yes, we can make an effort to get OPD records to be removed. But as of now, the government is moving very rapidly towards electronic health records. And what we are suggesting is, we should ask the National Medical Commission or Ministry of Health and Family Welfare to provide us the platforms where they want us to store the records. Because tomorrow I hire a party and they provide me the software and I keep uploading my records. Supposing they misuse, you are going to hold me responsible for the violation of the privacy. Here, if the platform is provided by a National Medical Commission or the Ministry of Health and Family Welfare, or they approve a particular private vendor, and we are using it, our responsibility goes. So this is something, of course, the main issue of whether OPD records should be maintained or not still remains. But as I said, government is moving very rapidly in this direction, and we are becoming dinosaurs who do not use electronic health records or maintain electronic prescriptions. Then if any request is made, we already know 72 hours used to be the timeline given in the previous regulations, as well as what has been mandated by courts. This here has been extended to 5 days. And what we have added is health insurers should be permitted only to take certified copies of the medical records. They should not be taking original health records. This is very important in certain situations where actual reports are taken up by the health insurers, and the doctor who's going to follow up the patient does not have access to actual photographs or actual films, which is not correct. Then the efforts shall be made to computerize medical records for quick retrieval. Again, the platform should be provided by Ministry of Health and Family Welfare or National Medical Commission. Section 16 says practicing euthanasia shall constitute unethical conduct. However, Honorable Supreme Court in Common Cause Society versus Union of India and Aruna Shanbag case have already defined the procedure laid down for passive euthanasia. That is a separate issue, that the procedure which has been laid down is so convoluted that nobody can use it. But this word getting in between, that practicing active euthanasia, will be helpful, lest some doctors fall foul of this rule later. As far as informed consent, it is mentioned that anything which can cause infertility, it should have husband and wife signature, but sometimes MTP can also result in infertility, and this has to be specified that for MTP, where the patient is composed mentis, only patient's consent is necessary. Also, where artificial reproductive technologies are being used, artificial insemination is being used, it is mentioned here that you have to have consent of female patient, her spouse, as well as the donor. I am not a gynecologist, my wife is, but I'm confused on this issue, because as far as my understanding goes, the donor should remain anonymous. If the donor is anonymous, how can you have the consent of the donor? Then duties of RMPs towards their patients. Emergency, yes, we are supposed to provide emergency services. However, this is to be added that an RMP is entitled to be reimbursement for his services either by patient or by the government, as suggested in Law Commission of India report of number 201. This is already in official records, though this is 2005 or 2006 document. Point is, everybody pontificates on doctors, ki emergency you should treat, you should be human in your outlook. I mean, we are having these preachings in tabular form in these regulations, but my right to the recovery of the amount I spend in an emergency. If a person has GI bleed and I have to do an endoscopy or an endoscopic variceal band ligation, or if a person is having a heart attack and he requires a primary angioplasty, does the RMP need to do it free of cost? You are making it a statutory requirement that I need to provide emergency services. Fine, we will provide the emergency services, but who pays for it? If the patient cannot pay, fine, let the government pay. And this is already suggested by the Law Commission of India report. So add this thing over there in your suggestions. Then is the issue of use of alcohol or other intoxicants during duty or off duty. So I think this or off duty has to be struck off boldly, because that will effectively create a problem for all doctors everywhere. If I am going to a marriage party and I'm having a drink and a patient of mine sees me over there, I mean, this kind of language can create a problem. Another thing we need to add is operating under influence of alcohol taken during off-duty hours would also constitute misconduct. However, working or being made to work for more than 12 hours at a stretch would also constitute misconduct, since sleep deprivation can also affect decision-making or skill in treating a patient. There was an argument on this issue that gynecologists who are working sometimes 24 hours at a stretch can sometimes be hauled up for misconduct in case they are working too hard. The point of introducing this here is the resident doctors who are made to work, because when we used to work, our long weekend used to be 72 hours consecutively. But in those days, we never faced violence. We did not have these Consumer Protection Act, and we should not compare what we were doing with what is happening today. We should not expect the same thing from our youngsters. I think some wordings can be changed over here, but residents being made to work for more than 12 hours at a stretch. You are saying on one hand that is equivalent to 0.1% alcohol in your blood. So if it is going to affect your decision making, and the person is going to make a mistake. How are you permitting this if you are not permitting me to operate under the influence of alcohol? Confidentiality, again for cashless hospital, the same thing which I had mentioned earlier. Section 26, patient care. RMP is free to choose whom he will serve, except in cases of life-threatening emergency. Having accepted a case, RMP should neither neglect the patient nor withdraw from the case without giving adequate notice. What is adequate? There is no definition of adequate. So I have added over here a notice of 24 hours to the patient is a must if you wish to withdraw from treating the patient, unless the patient has been abusive, violent, or something like that. For follow-up consultation, section 27 says should be planned as required by patient. I think this needs to be changed because the patient can feel he does not need to be seen for the next 2 years and he can simply take the medicines which were given. So point is planned as is deemed necessary by the RMP based on the condition of the patient. This is the necessary change which is required over here. Section 32, doctors who come from the government side for PCP NDT inspections, for other inspections in hospitals. This is regarding them, and what we have added here is inspecting RMP should keep the report confidential and not make it public except when required by the law. Yes, RMPs and the families should not receive any gifts, but then there is also a line here. Also, RMPs should not be involved in any third-party educational activity. This activity is being done by Jagsonpal. We should not be involved in this activity. Otherwise, this is misconduct as per these regulations. Thankfully, these regulations are not notified as yet. But the point is, this line has to be deleted. RMP may be required to file an affidavit regarding their financial earnings. Where do you want this affidavit to be filed? He is already declaring his income from all sources in his income tax returns. And that too for past 5 years, he is supposed to deposit as an affidavit. Where? It is a matter related to the income tax. If you wish to, the National Medical Commission wishes the income declarations of, I mean, everything is linked nowadays. My PAN card and my Aadhaar card and everything is linked. Why can't you access the information? Why do you need me to submit an affidavit for past 5 years? And this is the most worrisome. Any violation of these regulations or other applicable acts related to medical practice shall constitute professional misconduct. In this line, they have ensured that all doctors, irrespective whether he is director PGI, irrespective whether he is a resident who has joined, irrespective whether he is an MBBS doctor practicing in the periphery, each one of us will face a complaint of misconduct, will be prosecuted for misconduct at least once in our lifetime. This is something which has to be worded differently. This has to be, and the procedure for a complaint of professional misconduct. Any friend can also file a complaint. Please delete this when you send your suggestions. A friend should not be in this definition. And what is the definition of gross misconduct? They have mentioned that RMP, EMRB or State Medical Council can initiate suo motu case in case of gross misconduct. But what is the definition of this gross misconduct? That is not mentioned anywhere. Other thing, in the manner of inquiry, it is mentioned that at the time of filing the complainant shall submit to State Medical Council or EMRB. So effectively, a patient has an option either to file the complaint in State Medical Council or in National Medical Commission, EMRB. Why should that be there? If a patient is filing a complaint in EMRB, then under those circumstances, my right to appeal goes. Yes, you can say where a State Medical Council does not exist. There are 7 union territories in India where State Medical Councils are not there. There are 1 or 2 states where State Medical Councils have not been formed. Yes, in there you can say that the State Medical Council in the adjoining state or maybe National Medical Commission, EMRB, but then some kind of mechanism for appeal has to be retained. Another thing, in section B, they are saying if an email has been sent, that is sufficient proof of delivery of a notice. Here we have added that as well as a physical copy, because we know many doctors do not access their mails on a regular basis. So a physical copy has to be added over here. And the reply should be given at least 30 days from the receipt of the document, not 15 days as has been mentioned. Section 40 says, shall not be allowed to bring a lawyer. This, in my view, is against principles of natural justice. But then again, there will be debate on this issue, so you can make up your own consensus. Another, in section 40, I, subsection I, it says the complaint cannot be withdrawn after it is admitted by State Medical Council. Why? I have failed to understand this. A person is making, you are willing to compound criminal offenses, but a complaint to the State Medical Council has been made and the doctor and the patient have, let us say, settled. This is what you are concerned about. Let us say they have settled and the patient says, fine, I have no complaint. Why are you not permitting the complaint to be withdrawn? You want to be overloaded like other judicial fora with litigation. Similarly, this fact, section 41, subsection 5, Dr. Lele mentioned this thing. Please make sure this gets deleted. May restrain the RMP from performing clinical procedures or examination as deemed fit till the time, or holding suspension, restraining the RMP from practice till his case is decided. You have the luxury of deciding the case in whatever time you want. There is no penalty on you. But the RMP is penalized automatically while you are in your luxury deciding the case. This section has to be removed. Another thing is, powers of civil court have been given to under the Code of Civil Procedure to a State Medical Council or this Ethics and Medical Registration Board. This is a very, very tricky issue. If you are giving the powers of civil court, you cannot deny a presence of a lawyer there. The powers of civil court are cannot be restrictively applied to a particular quasi-judicial body. But then proper legal opinion may probably be needed on this. And as for emergency cases, it should be commensurate with facilities and competence available to treat in an establishment, and the necessity to treat an emergency should be made statutory only in establishments which display 24-hour emergency board outside, not otherwise. Informed consent, they have gone on to the Montgomery as the decision on which to base an informed consent. This is not what India or the law in India is. We need to follow Samira Kohli versus Prabha Manchanda judgment. And this is based on the Sidway and Bethlehem Royal Hospital Governor's case. We should not be following the Montgomery. Montgomery wants you to be detailed in whatever complications can happen to a patient, whereas real and valid consent is what normal doctor, another normal doctor would explain. If that is what you have done your job properly. So again, which any other reasonable doctor would share, not patient specific, it is doctor specific, that another doctor, let's say my wife is taking consent for cesarean. If she has explained the same complications as Dr. Ragini has to her patients, then what she has done is correct. The consent should be procedure specific, and the consent should be made available after prior approval from SMC or EMRB. This is very strange. There are 70,000 hospitals in our country. Each hospital develops a consent for normal vaginal delivery, sends it to the State Medical Council. The State Medical Council approves 70,000 consents. And after that, they can use it. And there are 5,000 odd medical and surgical procedures which are normally performed in modern scientific medicine. There are to be 5,000 into 70,000 such consents to be sent to the NMC. I don't know what they want. Very, very simple. Please provide pre-printed procedure-specific consents on the NMC EMRB website. We are not going to apply our mind. You provide us the consent, we will use the consent. Whatever is mentioned in the consent, we will tell the patient and make sure the patient understands. But we are not going to keep making consents, sending it to you for approval, and then that being used. Also is the issue, who can take a consent, whose name should be on the consent. These are all issues which need to be tackled. We have made our suggestions. It is in public domain. We can share it again if anybody wants it. In the consent, you need to take consent for anesthesia and blood transfusion. And the problem of what is to be done for children who are less than 12 years, they have mentioned over here 8 years. and assent from children less than 8 years. Because Indian Majority Act and all other laws in India, they talk of either 12 years or they talk of 18 years. This 8 years business has not been discussed. And in this particular regulation, this 8 years has come. Also, we know definition of consent. What we don't know is the definition of assent. What exactly is it meant when you say children should be giving assent? So witness, yes, in patients either who are vulnerable or patients who are illiterate or not conversant with the language of the land, their witness is necessary, and the definition of witness would be a person who can explain what is written in the consent to the patient in his own language. Please do not mention an independent witness, because there we will get stuck. Witness, from our point of view, the best witness is the person who will come to court and give evidence in my favor. So do not use the word independent over there. We should encourage all patients who are indisposed. Why indisposed? We should encourage all patients to assign surrogates who will take decision and give consent on their behalf. It should not be restricted to those who are indisposed. Sterilization, we have already discussed. Refusal of consent should be documented in medical records. And if documentation is done in the way like normal, in normal course of business, you do the documentation in that way, then it is evidence. So you don't need to worry about the patient has not signed the refusal of consent. You don't need to worry, I have not got it witnessed. If the patient refuses to give consent and refuses to sign the refusal of consent, document these things, sign these things, that is the end of the matter. Patients, RMPs should not request patients to share testimonials or recommendations, but then unsolicited reviews of my way of working and my abrasive style are rampant on the social media. And personally, I think I should be able to defend them, but then this is again then is the issue of soliciting patients directly or indirectly through social media. But the word soliciting has not been defined. What do you mean by indirect soliciting? This has to be defined. Number two, the organizations which can deliver the continuing professional development program. I think this part will be taken up by Dr. Sonia, so I will stop here. Thank you so very much. In case of any need, we can have a discussion later.
Yeah, thank you so much, Dr. Nagpal, sir. You have taken each and every section and you've added your comments, and I think all the people who have joined in have understood exactly कि ये NMC बिल जो हमारे हर एक के फंदा जो गले पे लटक रहा है, क्या हमारे पास सिर्फ 5 दिन है. Only 5 days we have to get it changed. Otherwise, our future generations are not going to forgive us. So let's all get ready and let's change it for our future generations, at least, if not for us. So next, I would now invite Dr. Sonia Malik ma'am to present her talk on clinical professional development. And after that, again, we will have the comments of our guests and our special guests. And again, we can have some question-answer sessions to our doubts. Thank you. And over to Dr. Sonia ma'am.
I'm honored to be a part of this. Thank you very much. I shall be very brief, not like Dr. Nagpal, because he is an expert and I am just quoting whatever has been written over here with a couple of remarks here and there so that we all understand what we are getting into. So this chapter is actually a guideline to tell us how the continuous development program guidelines are going to be set up, and this guideline actually deals with the process and delivery of the programs, the assignment of the CPD points, and the linkage of the CPD points with the renewal of licenses by the EMRB or the State Medical Council for all the RMPs. And of course, the penalties that would be involved in the event of non-compliance of the mandated CPD requirements. So therefore, it tells us that you have to keep on upgrading and upskilling yourself every 5 years if you want to practice. What then is the difference between CPD and continuous medical education program, which we are which we are conducting currently. We know that CMEs are basically targeted for a group of people, and they are basically the speaker is telling his opinion and his views all the time, targeted for technical skills and clinical management enhancement, and the formats are fixed or structured. Usually it is podium based. Now CPD on the other hand is a lifelong based on self-assessments addressing educational needs for better healthcare. It is learner-centric, comprehensive, and what is important is that it involves the effective communication, evaluation of emerging evidence, the practice of ethics, application of law in healthcare, etc. So it's basically not just knowledge skilling, it is also the skill it is also to enhance the skill of the practitioner in other areas which are related to his service of healthcare. Let me just go back to one point in the last one. And this basically means that basically we are trying to update in clinical practice, communication, management and behavioral skill, team building, information technology, audit and appropriate attitudinal changes to ensure improved patient outcome and satisfaction. So it is a huge order. They are expecting the doctors to learn all this through these CPD programs and ultimately be a better human being, so to say, because now, as everybody has been saying this, consider the doctors as not being proper human beings and not treating their patients properly. So who are the organizations who can deliver these CPD programs? They can be delivered by any registered medical professional bodies, whether they are association, state, national or international, medical colleges, hospitals, research institute, national institutes, government organizations, anybody, other institutions involved in healthcare training and education, which means that multiple CPD programs can be run by various organizations. And since the aim is to upgrade the skill of the doctors, will the same standard be maintained by all these organizations? That is something that we need to consider, because here on one hand you have the research institutes, and there on the other hand you have just the healthcare training processes which are basically there to upskill the doctors. So is the program going to be similar or is it going to be different is something that we need to understand and be aware of. So the organizations that will be conducting these CPD programs are responsible for developing the program, identifying the speakers, obtaining approval to conduct the CPD from EMRB and State Medical Council, disseminating information regarding the CPD to ensure enrollment, conducting the CPD, obtaining a feedback and submitting a report. So it is a total program which is going to be handled by the organization for its own doctors, and the training is to be supplied, is to be conducted by them to the satisfaction of the EMRB and the State Medical Council or the National Medical Commission, so that some training is imparted upon the doctors. However, will there be some training from the National Medical Council or the State Medical Council? Are they going to train us? Is there going to be some training, TOT also, which is going to be present? Because this is such a humongous program which is going to be conducted all across the states, all across the country, and with different types of organization, with different types of doctors attending them. Every doctor is not doing the same kind of practice, and hence the programs will have to be tailor-made to the needs of that particular practicing doctor. So what kind of a training is the National Medical Council going to impart and give to us? And about the delivery of these programs, they take the form of a face-to-face program, which is category 1 and 2. That means physical meetings, and an online self-paced hybrid form depending upon the nature of the CPD, which is category 3. I shall come to that a little later. Now, as they have said that you have, in addition to the knowledge skill upliftment, you also have to uplift the ethical standards of the doctor. You have to talk about statistics. You have to talk about data management and what all. So here is a list of some of the organizations which can be, from which help can be taken in order to develop the CPD program. This is what they have said, and the credit points can be mentioned against these programs which these people have developed. So therefore, it is not just us as healthcare providers, it is also others who are going to team up with us in order to form this CPD program, which is going to be a very, very difficult thing. I think it is going to be very difficult to have this kind of a cooperation or coalition with different organizations and start a program of this status of standard. So what are the categories of the CPD program? 70% of the program is to be devoted to knowledge skills. 30% of the program will be devoted to cross-disciplinary areas, which include bioethics, professionalism, communication, public health, policy, evaluating the evidence and biostatistics, etc. So imagine all this has to be done also, and this will constitute 30% of the CPD program. And this is the category 2 CPD. This will be helpful in improving the quality care backed by scientific evidence. And the third category is the self-directed online CPD scholarly work, which includes your paperwork, which includes the kind of journals that you have, to which you have submitted your original articles or whatever you have been doing in the form of research. So the question is, when is this expected to be initiated after the rules are notified? How long will it take? Will it take just 1 year to do all this? Have they already started thinking about it? No timelines have been suggested. And most importantly, as Dr. Nagpal also said, and the others have also said, where is the funding going to come from? Who is going to fund all this humongous program, such a huge program? How are we going to develop this and percolate it to the last doctor on this in this country? Also, how are we going to do it conducted time and again? Where is this huge funding going to come from if we are not allowed to take anything from the pharma companies? So what if not, then are we going to charge a fees from the doctors? And if we are going to charge a fees, is it going to be similar for the super specialist and for the GP who is practicing in the village? Because of the various, and then are we going to charge the doctors who are working in the medical colleges and hospitals? Is it going to be similar for all, or is it going to be different? Nothing is stated in this document. So what about the guidance for us, for the registered medical practitioners? So this is very clearly mentioned that this is applicable to all registered medical practitioners. Every RMP is required to reflect on his or her own professional needs, and this will allow them to register for CPD programs based on their individual needs, because all the CPD programs are going to be linked to the website of the EMRB, and you can go on there and select your own programs. I will come to that a little later. Every RMP is responsible to meet their mandated CPD points on a yearly basis, and every RMP is required to maintain a record of their CPD points, and the RMP, SMC, EMRB to update onto the EMRB State Medical Council portal on a regular basis. So if you have gained 6 points, it should be there. So when you go onto the website, you should be able to see that you have achieved 6 points over there. Your record will be maintained on the State Medical Council or on the EMRB. RMPs must be aware of the penalties that accompany non-compliance with mandated CPD points. This is not mentioned in this section, although it is again and again mentioned in various paragraphs in this document, but the penalties are not mentioned. I would request Dr. Nagpal to highlight these in case he has found them somewhere. I could not. So RMPs must be aware that mandated CPD points constitute a minimum requirement, and they are encouraged to enhance their CPD exposure based on their needs assessment. This is self-directed. So all the doctors have to actually understand what is their need, and depending upon that, they have to enhance their knowledge and their skills by attending both category 1 and category 2 CPDs in a proportion of 70 to 30. 70% would be the knowledge, and 30% is the skill enhancement. Not more than 50% will be category 3. So the third category is not going to be more than 50% of the total. Out of the rest of the 50%, 70% will be category 1 and 30% will be category 2. So what are the roles and responsibilities of the state medical councils? On the other hand, they are supposed to keep a database and record of all the RMPs. They are supposed to disseminate the CPD activities, auto reminders, suggestions for CPD-based programs in the area to the various organizations, and for creating a portal linked to EMRB for uploading the credit points of each RMP in their state to get the review of proposed CPD programs submitted by the organizers, etc., to enhance the expertise of medical education units. So therefore, even this part is rather huge. the state medical councils will really have to gear up to be able to do this kind of a thing. They have to really be able to now promote this or propagate this. And I think that is also going to take a lot of time. So there has been an EMRB CPD committee that has been set up, and this committee is for the assessment of eligibility and promotion of the CPDs. So basically, this is not only going to identify the organizations which are going to sort of impart this CPD program, and they are also going to look at the eligibility of the CPD, sorry, the promotion of the CPD, and also to look at the CPD program, whether it is worthwhile or not. So they are responsible for the entire CPD program once it is submitted to them for allowing us to take it on. So before rolling out the CPD program, it will have to be presented to the EMRB committee for assessment and final eligibility of the program. The most important thing is the credit points. Now, every year you are expected to get at least 6 CPD points. If not 6, then at least 3 credit points. Otherwise, you will not be able to complete the 30 CPD credit points in 5 years in order to renew your license. So you require 30 CPD points at the end of 5 years to renew your license. And the most important point is that while the faculty in recognized medical colleges and recognized DNB hospitals are engaged in training of medical students, routine medical education will not be allocated CPD credit points. So even this faculty will be required to achieve mandated CPD credit points as for other RMPs. So hence, all medical colleges teachers, everybody who is trying to even give education or impart education to students will be required to go through this CPD test or CPD credit points. So here is a framework. What is very, very interesting is that all these activities are given only 0.25 credit points per hour of active learning plus 1, 0.75. So if you have this kind of a rating, how many CPD programs are you going to attend to collect those 30 points or the 6 points in a year? This is something that we need to understand, because then it means that every month you would probably be attending 1 or 2 CPD programs in order to collect your 6 points for the year. This is quite a lot, and if we are going to fund them ourselves, then it also means a lot of funding which is going to be required by the organizers, and a lot of funding would be required by the RMP who wants to attend this program. He has to, if he has to self-fund it, he has to take out a bit of his money, bit of his salary in order to get into these CPD programs every year, every month, or maybe every 2 months. And if you look at the third category, you find that the maximum credit hours are given to publications, books, and journals. So basically, if you have done self-studying and self-research, maybe you will be a little better than the others, and this would give you more credit hours as compared to the rest. But remember, this is only 50% of the total credit hours that you have to achieve. So hence, everything has to be balanced properly. So to end my talk, I would just say that this is a very, very ambitious project, and I don't see it happening very soon, because basically the humongous amount of effort that is required to take on this project is great. And of course, there are no timelines that have been specified for its initiation and expedition. Different levels of programs would have to be created depending upon whom we wish to upskill. For instance, the village doctor or the doctor in a 3-tier city who is a super specialist, and the needs to be upgraded each year. This will also have to be upgraded each year, and a CPD bank will have to be created so that you can, like you have your own knowledge banks of books. Similarly, a CPD bank may be created by the EMRB probably, or us, the program, the ones who are running the program, so that we can bank upon it and use it each time. Dissemination is going to require a lot of time and money, and so where are we going to get that? And funding is going to be a major, major problem. That is something which the government has to consider. And the fees, of course, if it is going to be there, is it going to be variable or similar for all of us? That is another point of contention, and that needs to be really, really sorted out. Thank you very much for your attention.
Thank you so much, Sonika. I think Dr. Yashodhara wants to speak something.
Yeah, please.
Yes, ma'am.
Am I audible?
Yes, yes.
Okay, thank you. Ragini, congratulations for organizing such a conference, webinar on the issue of bringing everybody together on this platform. After Dr. Neeraj, listening to Dr. Neeraj Nagpal and Dr. Sonia and all stalwarts, probably nothing is left to say. But I still say we should appreciate the Government of India and NMC effort to bring the transparency into the medical system. But first thing, to bring this transparency, they have to stop comparing or stop the jhola chhap doctor at the periphery and grassroots, because this is the major issue which is providing us and giving us all the problems. All these patients who are being treated by them are coming to us in a very, very neglected state. We are not, nobody is going to criminalize them. Nobody is going to court them. That why they have been treating which they could not understand, which they could not do anything. So first thing, they are practicing allopathy. They're writing that they are BMS. They are writing this. First thing, first step is to stop this. Only then something can be done. So my is only thing that first the government NMC should bring a bill to stop all these practices which are happening at the periphery and the cause of so much of healthcare carelessness in this thing, in the health system.
Thank you. Thank you.
Can I answer that question, Ragini?
Yes, madam.
Dr. Yashodhara, sorry, I wasn't there when the earlier remarks. See, I think Dr. Nagpal has very clearly mentioned that this bill has already been passed. What we are here today, madam, one minute.
Sonia, no action.
One minute. We are here today to discuss and possibly help to change these rules and regulations which have been put up on the public domain. You have to concentrate only on this 104 pages. What are the sections? What are the points that which are not acceptable to us and which we want to change? And what you are suggesting, madam, is a huge thing. It's a different thing altogether. We will have to take it up on a different ground. Today, we are here only to discuss what is in these 104 pages. That is the difference.
Dr. Sonia, I totally agree. But all these regulations which are being made so difficult, which are not, they make practice. They have thousands of the rules till today, but nothing has been practiced. So they should make something which is doable, as you have said about the creditors. They should start with something which is doable. That is what I'm trying to say. They should go into the things that the suggestion is that all the points which they have covered, they should be doable. They are making it so difficult that no doctor would like to practice. And if the doctors are not practicing, they are able to get their objectives to bring health to everyone?
They won't be able.
Will they succeed? No. So only on our shoulders they are succeeding. They have increased the life expectancy. They have decreased the mortality. Everything they have reached. But still they are only trying to they're trying to control us only.
ये तो क्लियर है मैडम, अभी तो उससे जो है थोड़ा बहुत बच जाए, ये तो जो हो गया हो गया.
I think Dr. Nagpal has to go.
Doctor, 5 minutes more. Dr. Kiran Pandey, do you want to say something? Then it is open to discussion. Dr. Malhotra or any one of you can say ki what we are going to do in 2 lines. Dr. Tandon is there, and then we will disperse and discuss on the board. Unmute कर लीजिए किरण.
Thank you, Dr. Ragini. It's a very nice initiative, and actually where your comments and they were that we were not reading it. They were really too. I have tried to, again, there was a little less time in the work pressure exam, but still I tried to read all those 100. I mean, major part of 104 pages. It's a Dr. Nagpal has explained it actually very nicely. Important thing is कि main thing जो सब शायद Dr. Yashodhara is feeling, everybody is feeling कि सब हमारे ऊपर जो रूल्स एंड रेगुलेशंस लग रहे हैं, दे आर वेरी, ठीक है, रूल्स एंड रेगुलेशंस में रहना है, दैट इज ओके, बट दे शुड बी वेरी क्लियर एंड बायस्ड नहीं होने चाहिए। वो मतलब सारा का सारा जो एलोपैथिक डॉक्टर्स के ऊपर ब्रंट हर तरफ से घूम के, इधर से घुमा के और उधर से घुमा के आ रहा है। तो हमें अपनी पोजीशन को किसी न किसी तरह, जो पॉइंट्स अभी काफी अच्छे पॉइंट्स डॉक्टर नागपाल ने बताए, और सही बात ये है कि इसको और एंड और जितनी बार स्टडी किया जाए, ओनली देन वी कैन कम आउट विद मोर आइडियाज। डॉक्टर मलिक ने भी अभी जो कंटिन्यूइंग प्रोग्राम डेवलपमेंट करा, भी वो बहुत अनक्लियर है एक्चुअली में, कैसे करा जाएगा। हाउ आप लोग भी फॉक्सी एसोसिएशन जो एक रिकॉग्नाइज्ड है, उसकी बॉडी के वाइस प्रेसिडेंट हो, तो मतलब यू मस्ट बी ऑलरेडी नोइंग इट कि किसी भी प्रोग्राम्स को, प्रोजेक्ट को डेवलप करना, बनाना पूरे ऑल ओवर इंडिया सेम यूनिफॉर्म पैटर्न पे, बट ठीक है, उसके रूल्स एंड रेगुलेशंस थोड़े क्लियर करे जाएं, ज्यादा थोड़ा इजी करा जाए, दैट वुड बी बेटर, सो दैट वी कैन वर्क अपॉन इट।
करना क्या है, और तो डिस्कशन तो हो गया, आप करेंगे इसके बाद, सब लोग ने बस बोल तो लिया, कोई तो बताए अल्टीमेटली करना क्या है।
मेन तो ये है कि आई थिंक डॉक्टर रागिनी जो एक कमेटी हम ही लोग के जो यहाँ पे अपने फॉक्सी की जो मेन कमेटी है, वो जिन लोगों को बनाए, वो उसको मिलके एंड बहुत ज्यादा गवर्नमेंट के साथ, एनएमसी के साथ बार बार बैठना होगा, उनको प्रेशर में, मतलब उनको एक लेना पड़ेगा कॉन्फिडेंस में कि नहीं, वी हैव टू बी गिवन चांस टू पुट अवर पॉइंट्स। जब तक हमारे पॉइंट मतलब तब कंसिडर करा, उसको फाइनलाइज करा जाए, तो दैट इज द ओनली ऑप्शन कि जो हमारे पास प्रेसिडेंट्स हैं, इमीडिएट प्रेसिडेंट हैं, जो आप लोग वाइस प्रेसिडेंट हो, उनकी एक मतलब एक ऑर्गेनाइजेशन इतना लार्ज नंबर एक मिले एंड ये प्रेशर डाले कि पहले हमारे पॉइंट सुनने के लिए उन्हें अग्री कराया जाए, एंड देन वन बाय वन, इट इज नॉट अ मैटर ऑफ डे और समथिंग लॉन्ग
लॉन्ग का तो टाइम का है,
नहीं लॉन्ग का टाइम नहीं है, वो लेना पड़ेगा, मतलब कुछ ना कुछ तो टाइम लेके उसको, क्योंकि आप एक दिन में कितने पॉइंट्स या कितना समझा लेंगे उनको, वो समझेंगे ही नहीं जब तक कि उनके अंदर ये चीजें, नंबर मैटर्स।
डॉक्टर नागपाल, आपका क्या कहना है? हमारे पास में 7-8 किस्म के ड्राफ्ट हैं, तो क्या हम सब, मतलब मुझे जो समझ में आ रहा है, इंस्टेड ऑफ मेकिंग द वन ड्राफ्ट, वी शुड सेंड ऑल द ड्राफ्ट, जिसकी जो मर्जी हो उसमें से हिस्सा लेके चढ़ा दे।
That is one part, but what you are doing is something beyond what we have done. What we have done is we have studied it, we have made our efforts, we have created what changes we want. What you have done is you have gotten people who are influential together on a platform. This is something which is very sorely needed, because these are leaders in their fields, these are leaders in their organizations, and their say, when the same thing is said by them, carries much more weight than the same thing being said by me or any XYZ. So the point remains, yes, if we can convince these people that what is happening is wrong and these are the things which need to be changed, I think the galaxy of guests you have over here, these are the first people we need to get them to behind the idea. Then your point that individual points, if you see the NMC discussion group, I have made a very short one today and sent it. Basically, it is slightly caustic, but the fact remains the crucial points, the 7 crucial points I have discussed in that. And only those, if we can send or we can segregate into 7 different aspects, and individuals send those 7 points individually, probably that may be a better idea, have more impact. Rather than, because what we have sent is 104 pages expanded into 117 pages, I don't think they are going to read all that.
I think अगर हर आदमी ये ड्यूटी लेके हम अपने अपने शहर में 200, 400, 500, 600 जो भी डॉक्टर हैं, उनको मोटिवेट करके एक बार मेल तो भिजवाएं, उसके बाद अगला स्टेप देखा जाता है।
But what I'm saying is, like Dr. Punia has worked on CPD, let her send on CPD and in an expanded form. If somebody has worked on something else,
Yes, I think Dr. Nagpal is saying the same, almost same meaning कि हम लोग का जो पूरा 104 pages का है, अगर हम उसके कुछ divisions करके important लोगों को जो इस पे जैसे डॉक्टर नरेंद्र रुत्रा है, मतलब जो पास्ट प्रेसिडेंट जो इसमें knowledge रखते हैं, उनको एक पूरा 1 person कैन नॉट, तो अगर सेक्शंस में डिवाइड करके हर सेक्शन का पहले एक एक को देके उसके वो सारे पॉइंट्स निकाले एंड दैट कमेटी जिसको नहीं निकाल ले और जिसको एक बार कर ले, क्योंकि एक बार आप मिलेंगे उसके बाद दोबारा तिबारा का चांस नहीं मिलेगा. तो वंस इट इज फाइनलाइज देन द ओनली थिंग इज कि दैट कमेटी जो आपकी मेजर बने वो जाके उसे एनएमसी में ही बार बार उन लोगों से मिलना पड़ेगा, उनको कन्विंस करना है. और देखिए वी कान से कि ड्राफ्ट चेंज कर दो या ये कर दो, ये सब तो कुछ नहीं हो सकता. हम जितने चेंजेस करा लें अपने फेवर में दैट इज द ओनली थिंग पॉसिबल, क्योंकि बाकी सब कुछ ये सोचना कि कुछ वापस हो जाएगा कुछ हट जाएगा, वो तो फिर किसान आंदोलन की तरह हम लोग कहीं बैठ तो सकते नहीं है. तो वी कैन नॉट गेट दैट थिंग, वी कैन ओनली गेट थिंग कि हम अपने फेवरेट जो कुछ करवा सकते हैं, जितने पॉइंट्स पे उनको अग्री करा सके वो, दैट इज व्हाट.
चलिए सब लोग इतना प्लेज लें कि हर आदमी 100 लोगों से ईमेल तो भिजवाए.
मैम एक सजेशन दें क्या मैम, हम लोग का एक डेलीगेशन क्या प्रेसिडेंट ऑफ इंडिया से नहीं मिल सकता है? आई थिंक प्रेसिडेंट ऑफ इंडिया शायद वक्त लेके अगर सीनियर्स हमारे
इलेक्शन होने वाला है, जो बैठा है उसके पास है ही क्या
मैडम? प्रेसिडेंट से बात कर रहे हैं.
नहीं, प्रेसिडेंट ऑफ इंडिया का ही इलेक्शन बता रहे हैं ना, 24 जुलाई को तो अब न्यू होना है ना, तो वो
तो कब, ये तो 1 महीना है ना. he still can listen to us. कोई बात
प्रेसिडेंट ऑफ इंडिया मेरे ख्याल में सही व्यक्ति हो सकते हैं, बिकॉज वो फिर भी कुछ कर सकते हैं. एनएमसी में तो बहुत सारे लोग हैं मैडम, हम लोग कितने लोगों से बात
तो मोदी जी से मिला जाए या अमित शाह से मिला जाए तो शायद कुछ हो जाए.
हाँ, मतलब जहां भी अपॉइंटमेंट हमें मिल सके इन 3 लोगों में, बाकी तो कहीं सुनने का कोई मतलब नहीं है. कोई नहीं.
चलो पहला स्टेप तो ये करो, सब लोग 100 लोगों को पकड़ के मेल तो भिजवाओ. 22 तारीख के बाद देखते हैं, पहले मेल जाओ. सजेशन का पॉइंट
22 तारीख को अगर लागू हो जाएगा फिर मिलके
नहीं, लागू नहीं होगा उस दिन आपका हक बंद हो जाएगा कि आप उस ईमेल पे कोई लेटर लिख सकते हो. तब वो डिस्कशन शुरू करेंगे. तो 22 तारीख तक हम लोगों को मेल्स डलवाने हैं. एटलीस्ट 100 लोग को तो पकड़ो सब लोग. अगर हम यहाँ पे 40-50
करके मेल हम लोग उसमें भेजे मैडम, ताकि वो ही सब लोग फॉरवर्ड कर दें अपनी.
देखिए जितने ड्राफ्ट बन गए हैं उस ड्राफ्ट में से कोई भी पॉइंट निकाल के भेजा जा सकता है, और सब लोग अपनी एसोसिएशन के बेसिस पे एक कंप्लीट वो भेज दें कि भाई यूपीकॉग ये कहती है या HARObGyn ये कहती है. एक तो आपका कंबाइंड आपके एसोसिएशन से चला गया, वो एक अलग चीज होगी कि 20 किस्म की एसोसिएशन ने उनको लेटर लिख दिया. लेकिन अगर हर सिंगल डॉक्टर में 1 लाख तो खैर क्या 5,000 भी चले जाएं तो आज की तारीख में बहुत बड़ी बात है.
मैडम एक बात
हाँ जी बताइए सर.
आई एम डॉक्टर टंडन प्लीज. अभी बात हुई कि जो 22 तारीख है हमारा लास्ट डेट है. नहीं है, अभी भी शुरू में भी बात किया था कि जब ये 22 तारीख तक हम अपनी ओपिनियन दे सकते हैं, उसके बाद एनएमसी इसको स्टडी करेगी और उसके बाद ये पार्लियामेंट में जाएंगे, इन द बोथ हाउसेस, पार्लियामेंट, लोकसभा एंड राज्यसभा. उसके बाद ये पास होगा, तब जाकर के ये गैजेट नोटिफिकेशन आएगा, तब ये मिलेगा आपको. तो अभी बहुत टाइम है हमारे पास. 22 तारीख तक हम ये कर ले, मेल भेज दें, उसके बाद पॉलिटिशियन से मिलें, उसके बाद ब्यूरोक्रेट से मिलें, जिससे भी मिल सकते हैं उसको अपनी बताएं प्रॉब्लम्स. और जहाँ तक प्राइम मिनिस्टर और होम मिनिस्टर से मिलने की बात है, आई कैन एश्योर यू कोई बहुत ही उनका क्लोज हो तो आपको मीटिंग करा सकता है, बिकॉज वी हैव ट्राइड फॉर द 8 years. हर तरह से कोशिश करी, कभी मुलाकात नहीं है. ये तो कोविड की वजह से प्राइम मिनिस्टर एक बार फिर भी IMA के फोरम पे आके उन्होंने लोगों को कुछ बोला, कुछ बात करी. इज ओनली बिकॉज आफ्टर कोविड, अदरवाइज तो कभी मिलते ही नहीं है, कभी बात भी नहीं करते. तो उन लोगों से नहीं, अगर आप ब्यूरोक्रेट्स और हेल्थ मिनिस्टर तक के ऊपर पहुंच के और अपने जितने भी पॉलिटिकल पार्टीज के लोग हैं जिनको भी आप जानते हो, वो अगर अपोज कर सकते हैं आपकी प्रॉब्लम्स को पार्लियामेंट और राज्यसभा में, तो शायद आपको कुछ बेटर रिस्पॉन्स मिल सकता है. बिकॉज एनएमसी में आपके लोग हैं, देयर आर सो मेनी डॉक्टर्स एंड प्रोबेबली हर स्टेट से 2-2 लोग आए हुए हैं. You must be knowing everyone, पर उनसे कोई फायदा नहीं हो रहा है. क्यों? क्योंकि जो रेगुलेशन बनाने वाले लोग हैं वो डिफरेंट है. दैट इज द बिगेस्ट इशू. तो उसके लिए हमें पॉलिटिकल प्रेशर, ब्यूरोक्रेटिक प्रेशर अगर हम करा सकते हैं तो डेफिनेटली वी कैन गेट समथिंग. अपनी जो पोजीशन है, ऑब्जर्वेशन है, वो 22 तक भेजना है.
डॉक्टर कंचन, मेरे पीछे लिखा हुआ है वो ईमेल आईडी मेरे बैकग्राउंड पे, emrb.ethics@nmc.org.in. मैंने वो ईमेल आईडी लिख रखा है जिससे सब लोग लगातार उसी ईमेल आईडी को देखें, जिसपे हमें, मैंने 1 लाख का सपना देखा था. 1 लाख तो दूर, 5,000 भी चले जाएं तो बहुत बड़ी बात होगी. ठीक है, आई थिंक ज्योति
मैम हर रोज हर आदमी भी अगर बार बार मेल करेगा तो भी हमारा नंबर बढ़ेगा. हम अपनी अपनी सोसाइटीज में भी, अपने लोकल डॉक्टर्स में, अपने IMA ग्रुप्स में, अपने अदरवाइज सोसाइटीज में भी लोगों को कह सकते हैं, क्योंकि अभी हमारे पास सिर्फ 5 दिन और हैं मेल्स डालने के लिए. इस ग्रुप में भी हम कम से कम 150 लोग जुड़े थे, तो वो सब भी अगर रोज 5 दिन भी मेल डालेंगे तो शायद हमारे मेल्स का नंबर बढ़ जाएगा. और तब तक हम फिर अपने अपने एरिया में अपने हेल्थ मिनिस्टर को, हेल्थ सेक्रेटरी को, जैसे डॉक्टर NM साहब ने बोला, हम मिल सकते हैं. और एक कुछ ना कुछ मूवमेंट, इस मूवमेंट को हमें कंटिन्यू रखना पड़ेगा. ये नहीं है कि 22 तक हम मेल डाल के और चुप हो जाएं. So I think this movement has started. We need to continue this movement. And I would like to thank each one of you who has joined us today. We had so many UP coordinators, the different societies, all the presidents and secretaries of UP, Agra, Aligarh, Allahabad, Azamgarh, Bareilly, Bijnor, Bulandshahr, Faridabad, Faisalabad, Firozabad, Ghaziabad, Gorakhpur, Greater Noida, Hapur, Jhansi, Jaunpur, Kanpur, Khora, Lucknow, Mathura, Mau, Meerut, Muradabad, Muzaffarnagar, Noida, Saharanpur, Shahjahanpur, and Varanasi. All the presidents and secretaries of all these UP societies of FOGC. I'm thankful to each one of you for giving your support, and I'm thankful to all my special guests. I think some of them joined and they could not, because of the paucity of time, we could not take their comments. Dr. Niharika is so, but now she's not there. Dr. Preeti Kumar, Dr. Rakhi Singh,
Rakhi was there.
Was there. Now they are not there, ma'am. So, and then we have, I think Dr. Punita was there.
Yeah, Punita.
IMA Haryana. I would like her to also please speak a few words. Then we have Dr.
Thank you,
Kanchan
Dr.
was, yeah, and Dr. Divya Saxena, the IMA Haryana secretary, has been logging in for the last 2 hours. I think we need your comments as well, Dr. Punita, Dr. Divya, Dr. Kanchan, and anybody whom we have left, please raise your hand so we can take your comment. Your each comment is very precious. Thank you for joining us. Dr. Punita, please.
Yeah. Thank you so much. बहुत अच्छा सेशन रहा सबकी, बहुत अच्छे. नागपाल जी का तो डेफिनेटली हमें पिछले 5-6 मीटिंग्स अटेंड कर चुके हैं. आई थिंक हर स्पीकर ने बहुत अच्छे से अपना व्यू रखा. डॉक्टर रागिनी, डॉक्टर ज्योति ने जैसा कहा है कि हमें डेफिनेटली.
Ragini, again, I really appreciate and admire your efforts, the way you have taken pains for the last almost a month, putting up the ideas, putting everyone together. Great job. Really carrying on. 3 cheers for you, Ragini. Really, I appreciate.
Now we should.
ठीक है, पे ऑटो करना है, I think.
Yes.
और अमृता.
Yes, ma'am.
प्यारी प्यारी आवाज से.
Thank you so much, ma'am.
Deepika ji.
Ma'am, Jagsonpal would like to take this opportunity and thank everybody for joining in today. And with your permission, now we close the meeting.
Oh, thank you so much, Deepika. You are so prompt. I really appreciate your efforts and your job. You have done your job very well.
Thank you very much, ma'am.
नमस्ते मैडम, नमस्ते
Thank you,
पूजा
madam.
मैम।
Namaste, madam. Dr.
Good
Usha Sharma,
night.
madam.
मैम
Dr.
एंजॉय करिए,
All
वहाँ
the
पे हम लोग
best.
आपको वहाँ भी परेशान कर रहे
Hello,
हैं।
Kiran. Hello, Kiran.
Thank you,
madam,
Dr.
ji,
Hitesh.
madam, ji,
Thank
madam.
you so
Okay.
much.